Thank you. I request Dr. Jaj Reddy Garu, Organizing Secretary, to please come on to the dais. Welcome, sir. Thank you. Thank you all. Now, we are going to begin our session with lighting of lamp. I invite all the dignitaries to kindly lit the inaugural lamp and make this event successful. Thank you, everyone. I request you all to take your places. Now, I request Dr. Pushpalata, resident of Institute of Mental Health, to begin the event with prayer.
Good morning, Vanada. I'm Dr. Pushpalata, first year PG. Ya kundendu tusharahara davala ya shubhravastranvita ya veenam varadandamanditagara ya sveta padmasanam samam patu saraswati bhagavati nisheshajanyapaham.
Thank you, Doctor. I request the presiding officer, Dr. G. Jagannath Garu, to take over the session. Thank you, sir.
Thank you, Dr. Rajevi. Good morning, everyone. Respected chief guest of today's function, Dr. Gautam Saha, President, Indian Psychiatric Society. Guests of honor, Dr. Ram Krishnan, President of IPS South Zone Branch. Dr. P. Kishan, immediate past president of IPS South Zone, Dr. Uma Shankar, organizing chairman of the conference and superintendent of Institute of Mental Health, Hyderabad, Dr. George Reddy, organizing secretary of the conference, my fellow office bearers, Dr. Ram Subbareddy, Dr. Minhas, Dr. Vishal, and Dr. Sai Krishna, the past presidents of IPS TSB, all the esteemed members of IPS TSB, ladies and gentlemen. On the behalf of IPS TSB, I welcome you all to the 6th midterm CME of Indian Psychiatric Society Telangana State Branch, which is being held at Institute of Mental Health, Hyderabad. First, let me express my sincere thanks to the chief guest, Dr. Gautam Saha, and guests of honor, Dr. Ram Krishnan and Dr. P. Kishan, for accepting our request to grace the occasion. I really congratulate Dr. Uma Shankar and Dr. George Reddy for choosing such an important topic as the theme, the marriage and psychiatry, which is a daily problem in our day-to-day practice. In my 3 decades of practice, I have attended the court at least on 7 occasions, and each time the reason is same, that is divorce on the ground of mental illness. My first case was way back in 1995 when I was treating a chronic schizophrenia patient with negative features who was showing minimal improvement. Her husband has applied for a divorce on the basis of mental illness, which was not disclosed to him before marriage. The honorable judge asked me only 2 questions. First one was, is she suffering from a mental illness or not? When I said yes, the next question was, is she fit for marital life? I was so surprised. I do not know what is meant by fitness for marital life. In the next few days, I am again going to appear in the family court where the wife has applied for divorce as her husband is suffering from personality disorder with alcohol dependence. She claims that he is not fit for marital life. మనము రోజు బోల్డని మెంటల్ ఇల్నెస్ కేసులు చూస్తున్నాం కాబట్టి మన ప్రొఫెషన్ అది కాబట్టి మనము అనేక విధాలైన మెంటల్ ఇల్నెస్ కేసులు చూస్తుంటాం. దాంట్లో క్రానిక్ స్కిజోఫ్రెనియా కేసులు చాలా చూస్తుంటాం. పేరెంట్స్ మన దగ్గరికి వచ్చినప్పుడు ఒక పర్టికులర్ క్వశ్చన్ అడుగుతారు, సార్ మా బాబుకి 30-35 ఏళ్ళు వచ్చాయి, వీడికి మా తర్వాత చూసుకునే వాళ్ళు ఎవరున్నారు, వీడికి పెళ్లి చేయవచ్చా? దానికి మన ఆన్సర్ ఏముంటుందంటే, మా పెళ్లి చేయవచ్చా అన్న మీరు అడిగితే మీరు ఈ వ్యాధి గురించి ఎదుటి వాళ్ళకి డిస్క్లోజ్ చేసి పెళ్లి చేయండి వాళ్ళు ఒప్పుకుంటే అని మనం యూజువల్గా చెప్తాం. దానికి వాళ్ళు సమాధానం ఏమిస్తారంటే ఇమ్మీడియట్గా, సార్ మెంటల్ ఇల్నెస్ ఉన్నాయంటే ఎవరైనా పెళ్లి చేసుకుంటారా సార్? మేము ఎవరో ఒక పూర్ ఫ్యామిలీ నుంచి ఒక అమ్మాయిని తీసుకొచ్చి పెళ్లి చేస్తాం సార్. Is it a curse to be born in a family of poor socio-economic background? And one more thing is, if a person has got a mental illness like a mania, first episode, and if they want to get him married off, మనకి తెలియదు మళ్ళా ఇంకొక ఎపిసోడ్ డిప్రెషన్ ఎప్పుడు వస్తుందో మానియా ఎప్పుడు వస్తుందో మనకి తెలియదు. మరి అట్లాంటి వాళ్ళలో మనం చెయ్యవచ్చు అనొచ్చా, చెయ్యకూడదని అనొచ్చా? చెయ్యకూడదు అంటే మనము ఒక పేషెంట్కి ఏ రైట్, పెళ్లి చేసుకునే రైట్ని మనం డినై చేస్తున్న వాళ్ళం అవుతామా? ఇవన్నీ కూడా మనం ఈరోజు డిస్కస్ చేసుకుంటాం. ఐ హోప్ ఐ విల్ బి ఏబుల్ టు గెట్ ఆన్సర్ టు ఆల్ దీస్ క్వశ్చన్స్ ఇన్ టుడేస్ CME. Today we have elite speakers and expert panelists, and I hope this is going to be a very useful CME. With Dr. George Reddy at the helm of the affairs, I am sure you will like the hospitality. So all of you, relax and enjoy the proceedings. Thank you. Now I request the organizing chairman, Dr. Uma Shankar, to give his message.
Good morning. Welcome you all. Respected our State President, Dr. G. Jagannath Garu, and today's chief guest, Dr. Gautam Saha Garu, and guest of honor, Dr. Ramakrishnan Garu, and my other colleagues, those who are presented here and those who are on online. I welcome you all for today's CME. I think this CME, most of the doctors, especially psychiatrists, those who start early, even after 20 years practice also, they are facing some difficulties to answer some of their questions. So with today's CME, some extent, not 100% I can say, some extent they can clarify, they can help to answer their queries. This is 6th CME after formation of Telangana. So I welcome all for this today's CME. Once again, I thank the organizing doctors, those who are helping us to organize this. I also thank the IPS TSB giving this opportunity to organize the CME. Thank you very much. Thank you, Varda.
Next is message by Organizing Secretary Dr. V. George Reddy.
Respected President, Indian Psychiatric Society, Telangana State Branch, Dr. Jagannath sir, and our beloved National President, Indian Psychiatric Society, Dr. Gautam Saha, the guests of honor for today, our beloved South Zone, IPS South Zone President, Dr. Ramakrishnan sir, and another beloved psychiatrist from our Telangana, guest of honor, Dr. P. Kishan, immediate past President, and all the office bearers, Dr. Ram Subba Reddy sir, Dr. Minhas, Dr. Vishal, Dr. Sai, and all the EC members and the past presidents here. We have Dr. Ashok Reddy sir, Dr. Keshavarao sir, Dr. Mayurnath Reddy sir, and we have all the senior members and postgraduates. Good morning. Without taking much time, I'm sure you all will accept this topic will be very useful, and we face so many problems, and trust me, this session was planned with only intention that I have planned only Hyderabad biryani today. There's nothing other than biryani today. So when I say Hyderabad biryani, the topic, the speakers, they are so well planned, and they're going to make this CME session a very useful one. And without much taking time, I think I hand over the mic to the President. Thank you, Dr. Jagannath sir.
Thank you, Dr. George Reddy. Now I request the Vice President and President-elect Dr. V. Ram Subba Reddy to give his message.
Good morning to all. Respected President Jagannath sir, and the organizing chairman Umashankar sir, and our chief guest Gautam Saha sir, President IPS, our guest of honor K. Ramakrishnan sir, President South Zone, our past President South Zone Dr. Kishan sir, and other office bearers of the Telangana State Branch, and the organizing secretary Dr. George Reddy. I welcome all the delegates to the 6th midterm CME. And today's CME theme is marriage and psychiatry. And this is a different theme from the routine one. I think in the past, no one had taken up this theme, even in the combined AP. I think this theme is going to help for the psychiatrist, how to solve the problems. And today we are having excellent speakers and excellent panelists, speakers like Mundra sir and Praveen Chintapati, and Dr. Sri Lakshmi, and panelists like Chandrasekhar sir, Kesharao sir, and Sridhar Rasu, and are all going to enlighten us today. Thank you, and thank the organizing committee for giving this opportunity. Thank you.
Next, thank you, Dr. Ram Subba Reddy. Next, I request Dr. Minhas to give his message.
Good morning, all. Dear all, on behalf of Indian Psychiatric Society, Telangana State Branch and organizing team of 6th midterm IPS TSB, I welcome you all. I won't take much time. The theme is marriage and psychiatry. Marriage, they say, jo khaye wo pachta hai, jo na khaye wo bhi pachta hai. So let us see how we deal with normal people. We have topics on normal marriages, which can lead to anxiety and other disorders. For that, we have some session for people who have psychiatric illnesses, how they cope up with their marriages and what to do about it. Thank you.
Thank you, Minhas. I acknowledge the presence of a senior psychiatrist, Dr. Ashok Reddy and Dr. Gauri Devi. Welcome you, ma'am. Next is a message by Honorary Treasurer, Dr. Vishal Akula.
Respected seniors and my colleagues, today's chief guest, Dr. Gautam Saha, sir, guest of honor, Dr. Ramakrishnan, sir, Dr. Kishan, sir, IPS President, Dr. Jagannath, sir, Vice President, Dr. Ram Subba Reddy, sir, and Organizing Chairman, Dr. Umashankar, sir, Organizing Secretary, Dr. Jaj Reddy, sir, and General Secretary, Dr. Minath, sir, and Dr. Sai Krishna, sir, and Ashok Reddy, sir, and Kesharao, sir, Mayurnath Reddy, sir, and Gauri Devi, madam. Dr. Gautam Saha, sir, Gautam Saha, sir, inspiration to all of us. The way of he has come to this position, surpassing all difficulties from ground level. It's a privilege to be associated with you, sir. And he's always encourages to take the lead of Indian Psychiatric Society. And Dr. Ramakrishnan, sir, today's guest of honor. He is leading South Zone in innovative way, like introducing monthly South Zone CME and initiating Samanvika Women's Wing and active participation in community psychiatry. And today's our guest of honor, Dr. Kishan, sir. He is an asset to IPS Telangana State Branch. He is active contributor to the society. And I would like to congratulate organizing Chairman Dr. Umashankar, sir, Organizing Secretary Dr. Jaj Reddy, sir, and Joint Organizing Secretary Minath, sir, for wonderful arrangements. As a treasurer of IPS Telangana, I would encourage everyone to take a membership to strengthen the IPS Telangana State Branch. Thank you very much.
Thank you, Dr. Vishal. Now I request the Honorary Retired Dr. Sai Krishna to give his message.
Good morning, all. Warm greetings from editorial office. Respected dignitaries on the dais and off the dais. Today, even I'm also waiting as a student to listen on marriage and psychiatry. I don't want to waste much time and hand over to the next person. Thank you.
Now we shall honor the senior member of IPS TSB and past president of TSB, Dr. Keshav Rao. Dr. Keshav Rao, please come onto the dais.
Thank you, Dr. Kesharao, sir. Dr. Kesharao, as you know, he's one of the senior most psychiatrists. He works both from the UK and India. We are very lucky to have him as our past president. And I was still more lucky to be his secretary. And it is really our privilege and honor to felicitate sir on this auspicious day. Thank you, Dr. Kesharao, sir. I request Dr. Jagannath sir, Dr. Umashankar sir, Dr. Kishan sir, Ram Subba Reddy sir, first to honor with a shawl.
Thank you. Thank you.
I request, sir. I request Uma Shankar sir. Garland. Thank you, sir. Kishan sir, to hand over a memento. Thank you, sir. We'll just join for a photo. Thank you, Dr. Keshwara, sir. Thank you very much, sir. We request Dr. Keshwara, sir, to give a small message.
Thank you very much. I very sincerely and from my heart, Telangana Psychiatric Society members for their support during my tenure, for giving me an opportunity to be the president. And most importantly, I am very happy that this branch is coming up very fast. It's the youngest branch in the country, but on all fronts, academic, journals, sports activities, in every field, we are moving forward. I hope that the branch will truly reach higher heights under the leadership of our young psychiatrists. Thank you.
Thank you, sir.
Thank you, Dr. Keshwara. Now I request Dr. Kishan to please accept our felicitations. So be seated. Request Dr. Kishan to give a brief message.
Thank you very much to Telangana State Branch, and that is enough. I'm going to give my message as a guest of honor shortly. Thank you.
Thank you, Dr. Kishan. Now I request Dr. Lata Ramakrishnan, wife of Dr. Ramakrishnan, President of IPS South Zone, to honor the guest of honor for today, Dr. Ramakrishnan, please. Ma'am, are you here, ma'am? Dr. Ramakrishnan Gardi, connect chain.
Thank you, sir.
అంతేనా వాళ్ళకి రీచ్ అయిందా నేను ఉండాలా వెళ్ళిపోతా
Okay. Thank you, madam. Thank you, ma'am. On thanks, ma'am, for felicitating sir on behalf of IPS TSB.
థ్యాంక్ యూ సార్
Thank you, ma'am. Sir Ramakrishnan sir, kindly give your message, sir.
Good morning to all of you. I sincerely thank all the organizers of today's the Telangana State Branch officers for the love you all showed to me. As previously, one guest was telling, the youngest branch in India is becoming more and more vibrant with the guidance of senior psychiatrists and the active participation and the enthusiasm of youngsters like George Reddy, Kumar Shankar, Mustafa, and all these people. I am really proud of this participation. When I came to Hyderabad, I had good friends there, and I'm happy to be with them. And today's topic, as such, as the inaugural speaker was telling, much needed one, especially we are dealing with marriage almost in every case. Marriage issue comes creeps in every case of psychiatry we see, either marriage proposal or marriage disposal or interpersonal problem, domestic issues, all are coming. So it is good thing that one full day is going to be spent on the various issues of marriage that as a psychiatrist we are going to face. Example, that the very first topic, the game of marriage, that is by Dr. Mudra itself is a good opener. And to tell or not, that is the question. That is everyday problem whenever patient, lady patient or gents patient is about to get married, and sex and psychotropics. Again, this is a very, very interesting, very, very difficult area to deal with. And with a good debate, Indian marriage system, and the panelists are all exemplary psychiatrists from this thing. Chandrasekhar, Keshav Rao, Sridhar Raju, Nivedita, no, she is very active in Samvani, and Dr. Preeti. All are this thing, everything is well chosen. I should congratulate the scientific committee for the choosing of this topic. Only thing I wish I had been there personally to have this Hyderabad biryani. Unfortunately, I couldn't be there. Maybe secretary can send a parcel. We all will be happy.
Don't forget me also.
Yes, sir. Yes, sir. I wish the function all success, and I hope that all the delegates stay till the end to listen to the all the aspects of marriage and other things, topics, have good scientific this thing, and let us continue the scientific work which will reach the community. Thank you, Dr. Gautam Saha, Dr. Kishanji, my senior predecessors and mentors for what I am today. Thank you so much. Long live IPS. Thank you.
Thank you, Ramakrishnan sir, for your message and accepting our request to grace the occasion. Now, before we go to the next point, I request Dr. Kishan to give his message, please.
9:45.
Respected presiding officer, Dr. Jagannath, President, Telangana State Branch. Today's chief guest, Gautam Sahaji, President, IPS National. Guest of honor, Dr. Ramakrishnan, President, South Zone, IPS, and Organizing Chairman, Dr. Umashankar, Organizing Secretary, Dr. George Reddy, Dr. Ramsubha Reddy, President-elect, Telangana State Branch, Dr. Minhas, Secretary, Telangana State Branch, Dr. Vishal, Treasurer, and Dr. Sai Krishna, Editor. Good morning to everybody. And really, I'm very happy to share this dais with my great well-wisher, Gautam Sahaji, President, National President of IPS, as well as my good friend, Dr. Ramakrishnan, South Zone President, and wonderful young brothers, Dr. Umashankar and Dr. George Reddy. I think everybody observing the show of Dr. George Reddy, almost whatever the arrangements today is almost like, even though it is a midterm CME, it's like conference. And the technology is using, and even not today's, when you can see last 1 month what is happening, the message is giving. So a lot of other well-wishers and seniors messages and trailers and with Sayata. So I think a lot of youngsters should learn from Dr. George about organizing skills. And I think he is getting a lot of good cooperation and guidance from Uma Shankar. He's a able leader in academic as well as professional activities. Coming to, I want to tell very briefly about the, for sake of benefit to the youngsters about Telangana State Branch. Everybody knows we the youngest branch of IPS state branches. With this short period, I think all credit goes to our elders, Dr. Chandrasekhar, Dr. Raghuram Reddy, Dr. Gauri Devi Madam, all the way she came here, irrespective of her other personal grounds, but she's now taking a responsibility as a women empowerment committee. So with these blessings, the journey of Telangana State Bank started. Dr. Raghuram Reddy Prana Pratishtha Chechi as a accepting first founder presidentship to the Telangana State Branch, everybody knows, and his guidance and his shadow is still continuing to guide all of us. Whatever the today's success, what Kesharao told, is goes to his soul is always running the show and always guides us in troubled times. And at the same time, Dr. George Reddy as a founder secretary, I served almost more than 4 years to our state branch with a strong foundation. And with this, the president, series of president, you can see Dr. Sridhar Raju. If you see his message in the trailer, it's raising as a very good human being. President, I've seen till his president's address there to me, how really I'm very proud to have a younger brother like him. And he's almost evolving like a prophetic level. No, what his message, if you thoroughly, deeply abstract understand it, very fine and very abstract. And after that, Dr. Uma Shankar, as a third president of Telangana State Branch, you know what are the value system Dr. Uma Shankar follows, and presently as a CEO of Telangana Mental Health Services, as superintendent of IMH, as well as is a teaching and is a state branch Telangana representative to the South Zone in IPS activities as well as growth of professional services in Telangana. And his contribution to Telangana State Branch is very recognizable and is especially, I think, with his conference, contributed a lot of amount to the Telangana State Branch. I think it is the highest amount to the Telangana State Branch, if I am correct. Then Dr. Kesharao, you know, everybody knows how value system he is. Still, he is having a lot of love on motherland. He comes all the way to India to spend 6 months here. There is no need, he will get a lot of money if he spends total time in London. So he accepted responsibility as the Telangana State Branch. In the rich Telangana State Branch, faced a lot of challenge. And always with all leaders of the Kesharao guidance and Raghuram Reddy. And next, Dr. Mayur, humble human beings like Mayurnath and Jagannath era started. And they're learning a lot of humility from them. Everybody knows about the gentleness of the value system. With the credit of Telangana State Branch goes to all these presidents, and Minhaj is almost going in the line of Dr. George Reddy, and a really a young and very humble person, and is doing wonderful work and will continue the legacy of George Reddy. And at the same time, Dr. Vishal is now Treasury. Telangana State Branch is one of the richest branch now when compared to other red branches. And credit goes to Gangaram as well as Vishal is continuing that legacy. And Dr. Sai Krishna, you see that today, now our Medno. When we started the journal, Medno rejected to publish our state journal and with some comments. Now, same Medno came and publishing our journal. So all credit goes to the foundation work done by Pani Prashant and Dr. And I think Sai Krishna is doing wonderful job in the same line, and Telangana State Branch is supporting him for all his requirements, and George Reddy father contribution. We should remember about a lot of RI and getting RI and all the things. So this is how Telangana State branch came up. And with this, I hear the legends are there, Dr. Ramakrishna ji and Dr. Gautam Saha. I want to tell a few words about South Zone as well as IPS. And with their blessings, South Zone as well as cooperation and IPS National is surviving, and a lot of guidance we got from IPS National when we got some troubles in our branch as well as in our growth. And coming to my South Zone, Dr. Ramakrishna ji is raising the bar. Still, South Zone is already wonderful branch. We got Best Zone Award last year. But again, Ramakrishna ji is raising the bar for all zones now. You see, every month, a lot of activities are going on. And today, Gauradevi Madam, all the way, she came here to take the responsibility of women empowerment. She's more respectable lady. When Jagannath asked me about share, so what are the senior members thing? Can I reveal her? I don't know. But when we discuss about Dr. Preeti, Nivedita, and Nanita, I think for this, Sri Lakshmi, all these are for young women. Dr. Gaudevi going to model as a professional leader, and they should come up with Dr. Gauradevi madam. Always I'll tell my students, I used to tell the Preeti, you must become next Gauradevi. So that is a madam, that is a spirit we are having. And all this credit goes to Dr. Ramakrishnan, who started the Women Empowerment Committee with a very big way by including all the states. His idea is all committees, he included all the states. That is stimulating all the states equally, not only in educational and South Zone. Thanks to Ramakrishnan ji for giving opportunity to share shortly. We are going to hold the CME at Telangana State Branch, which is going on ongoing work every month. And India, along with the Indians program, already on record, South Zone Indians program started by Dr. Jagadish and Dr. T.P. Sudhakar, that is continuing. And Ramakrishnan started a Wiser program, that is everyday CME, and it's collecting some amount to support the journal. No, some persons, how to get it. He's also a local Kalyana concept. He is collecting from the companies who are sponsoring the CME, and with this, supporting the journal. So along with this, Women Empowerment Committee and the community services, Vishal is here to how dynamic community services are going on in Kerala, and always Telangana State Branch is in competition in the South Zone of in community work as well as the academic works. And before going to my national contribution as well as the cooperation what we are getting from Telangana State Branch, and Gautam Saha is witnessing here. Telangana State Branch not only one of the rich branch, as well as within 6 years we developed our own journal, and with a good indexing, and we developed our richness. We are having orations. We contributed to the South Zone in a big way, and we are having other projects shortly to contribute to the South Zone and national levels. Along with this, and the credit goes to Dr. Uma Shankar, not only the aims and objectives, to fulfill the aims and objectives of Telangana State Branch, we got 2 Center of Excellence under his leadership, Dr. Uma Shankar, and all postgraduates were not recognized previously. Also, he has done a lot of work, and that credit goes to Institute of Mental Health, Gauradevi Madam, other professors here. And Uma Shankar also is instrumental in getting 2 Center of Excellence, one at this center, this IMH Institute of Mental Health, Hyderabad, one center at Warangal. Still, we are having interaction with the health minister to get it started. We already funds are there. So little technical problems, probably Uma Shankar and Dr. Srinath, professor head of the department of Warangal, is taking care of that. And we got increased number of postgraduates. Even all government medical college in Telangana got private psychiatry seats, and our private medical college, including the government college, started services. Next in the pipeline, Mahbub Nagar, Dr. is here. Mahbub Nagar and Nizam, and Mahbub Nagar is shortly, because the new medical college is shortly going to get in the postgraduates. So Telangana State Branch is thinking, and with all blessings of Dr. Gangadhar, we are getting whatever seats we want. He's favoring us, and we are getting a lot of postgraduates, and services are increased. Educational services and health mental health services are increasing and distributing over the two cities, that is Hyderabad and Warangal. And with this, I want to keep on record the national IPS contribution to us. They helped, including Dr. Murugesh Vaishnav and Dr. P.K. Dalal. They helped us a lot in solving the problems by giving 5-member committee and 3-member committee by Ajit Awasthi, and all those guided us in a proper way. And I'm requesting from this dais, Gautam Saha, we submitted our new constitution with the guidance of Dr. Ajit Awasthi, with the guidance of Dr. Ashok Reddy, other constitution member committees, and we submitted. It is on the table of IPS. I think sir is going to help us in clearing our new constitution, and we'll have all guidelines accepted by Dr. Ajit Awasthi guidance. We're going to have a new constitution shortly. And one more request, the Gautam Sahaji. Shortly, we are going to have, and at the same time, Telangana State Bank and South Zone, I'm requesting, we are going to hold the 6th World Congress of Religion and Spirituality in Hyderabad. Today, I'm going to interact with Dr. Prasad Rao to finalize the whole protocol and organizing committee. And we have a brief organizing committee meeting by Abdul Javed, President WPA, Avdesh Sharma. We are going to finalize today, sir. We'll coming to the same report. IPS already backing and supported our World Congress.
100%.
Yeah, World Congress report, sir. We are today or tomorrow, we are going to submit all the proposals with Avdesh Sharma is also there. And we shortly, I think in the November, we are going to have a World Congress with the cooperation of Telangana State Bank, South Zone IPS and National IPS at Hyderabad. Thank you very much to Gautam Sabha and National Happy IPS for always taking special interest on Telangana State Branch. And thank you very much, sir. And thank you to Dr. President, Dr. Jagannath, and Organizing Chairman, Dr. Umashankar, Dr. George Reddy, Organizing Secretary, for giving this opportunity. Thank you very much. Thank you.
Thank you, Dr. Kishan, for explaining in details the activities of Telangana State Branch. Next is, for a few moments, I am going to play the role of the National President and going to release the journal on his behalf.
Babu.
This will be the next phase page for our journal from Dr. Kluwer from June 2021. Thank you.
Great.
Thank you, Dr. Gautam Saha, for permitting me to release the journal on behalf of you. Now I request Dr. Madhumita Saha to honor our National President, Dr. Gautam Saha, on behalf of Telangana Psychiatry Branch.
Thank you so much.
Thank you, ma'am. Thank you, sir, for accepting our invitation. Ma'am, thank you for felicitating sir, ma'am. Thank you. Now I request Dr. Gautam Saha to give his message.
Good morning, everybody. It's a really great privilege for me to be with all of you. Maybe it is virtual. I'll be much happier if it is if I present there. But you know that a few days back, your invitation, I have attended the first. I broke that lockdown period and went to attend the Southern conference at Hyderabad. Telangana and Hyderabad is a real weak point for me. Not because I love the people of the Telangana branch, but the activities of the Telangana branch has done as extremely well. Respected President of the Telangana branch, Dr. G. Jagannath, guest of honor, Dr. Krishanan, another guest of honor, Dr. Kishan, and Dr. Uma Shankar, Dr. George Reddy, my brother, Dr. Minhaj, Dr. Vishal Akula, Dr. Sai Krishna, and other senior members present here, Dr. Ashok Reddy, Dr. Gauri Devi, Dr. B.K. Mundra, Dr. Kishore, and all other attendees over there. I'm really proud to be with you. In fact, if you see, Telangana branch is the youngest branch, but still they are doing lots of activity. One of the most active branch of the Indian Psychiatric Society, I proudly saying this, and their quality of works, if you see the journal with indexing within these 6 years, as Dr. Kishan mentioned, and Dr. Kishan has said that they have come up with a new constitution. I promise here, I will help my best from the national body to approve it. And you know that whenever I was the general secretary, I believe on the young brigade. If you see as for example, how a cricket team is good, at its best or not, it depends on its reserve bench. Whenever I became the general secretary of the Indian Psychiatric Society, I start working on the build up the young brigade of the Indian Psychiatric Society. You know that now I am really happy that in every part of the country are really strong. The young brigades, young psychiatrists have come up and they get interested in the Indian Psychiatric Society, and Indian Psychiatric Society has really now is vibrating. And I see in the Telangana branch, if you see there, it is a great mixture of young and contemporary and older generation psychiatrists. They are very good, and I'm really proud of you all. And today's topic is really, I congratulate the scientific committee of the Telangana branch. This is a marriage and mental health, marriage and psychiatry is a really very relevant topic. Somehow the clinical practice, we have to know there are lots of legal issues, and beyond the legal issues, we have to support as a psychiatrist, sometimes be a family member of the patient. We have to suggest how we can maintain. We have to talk to beyond our professionalism. We go to talk to the in-laws house to make the marriage successful. And there are something related to marriage and psychiatry, not only regarding the pharmacological things and how to do psychotherapy among these patients after marriage and pre-marriage is something different. So I am confident enough that today's scientific program will be great help to not only the junior psychiatric colleagues, also the senior colleagues like us. Thank you so much, Telangana Branch, for giving this opportunity to speak, and for this honor, I'm really grateful to you. Thank you so much. Thank you, everybody.
Thank you, Dr. Gautam Saha, for your message and blessing us. Now we'll go to the next point in the agenda, like distribution of mementos to office bearers.
Thank you, sir. I think on behalf of the organizing committee, we wanted to really felicitate our office bearers and DC. So I request first, I request Dr. Ashok Reddy sir, Dr. Keshoro sir, Dr. Uma Shankar sir to help us in giving mementos to the office bearers. Sir, run, sir. First, Ashok Reddy, sir, please give memento to our president, sir, Dr. Jagannath, sir. Sir, to Dr. Ram Subbareddy, sir, the Vice President, sir. Request Dr. Mayur, sir, to comment to Dr. Meena, sir. Request Dr. Umashankar, sir, to give memento to Dr. Vishal. Request Dr. Anurag, sir, to give memento to Dr. Sai. Next, request Dr. Kishan, sir, to hand over memento to Dr. Mayurnath Reddy, sir, our immediate past president. Do you have the EC members? Next, Dr. Sirisha, madam, Dr. Fani. Request Dr. Jagannath, sir. And I request Dr. Praveen Chintapanti, sir, to give memento to Dr. Fani Kant. Fani. Do you have any more EC members here? Where is Preeti? Yeah, hi. Sorry. Dr. Preeti. Yeah, Dr. Gauri, madam, please, madam. Okay. Dr. Ajay here.
Now it's turn to organize secretary. Now I would like to request Dr. Sridhar, sir, please come to hand over the memento to Dr. George Reddy, sir. Please come, sir.
I think Dr. Ajay is not here. Sir, with that, sir, I think I hand over the mic to our president.
Now coming to the almost the last point, vote of thanks by Dr. George Reddy.
Thank you, sir. At the outset, first, I would thank our national president, Dr. Gautam Saha, sir. The best part of the president, Dr. Gautam Saha, sir, is, I trust me, the way he interacts with us, we feel we are with our elder brother. The way he encourages, and I'm sure we are going to see an active year ahead. Dada, thank you for accepting our invitation to be here as the chief guest. And it will be a memorable for us. We started this year with you, and hope we will see you many more times to Hyderabad. And Dr. Ramkrishnan, sir, our South Zone president, sir is coming with so many innovative ideas. And though sir is a senior, the way he interacts with us, it makes us very homely. Thank you, Dr. Ramakrishnan sir, for accepting our invitation and to be our guest of honor. Thank you, Dr. Kishan sir, our immediate past president, South Zone. He is the backbone for our Telangana state branch. He guides us at every point of time and he takes up an active role. And to me, sir is younger than me in formulating things and the way he's active. Thank you, Dr. Kishan sir. And thank you, Dr. Jagannath sir, for giving us the freedom, liberty, and you never objected us at any point of time in going ahead with this midterm CME. And thank you for your blessing, sir. And Ram Subbareddy sir, our next incoming president, Dr. Minhas, I think he is the center of the show for organizing everything. And thank you, Dr. Minhas sir, for introducing Dr. Mundra sir, a senior learned psychiatrist, and our treasurer, Dr. Vishal. Thank you for helping us in getting the CME credit hours and being here as the dignitary. And Dr. Sai, thank you for being with us and taking care of the association. And all the senior members who are here, Dr. Ashok Reddy sir, Dr. Anurag sir, Dr. Keshav sir, Dr. Mayurnath sir, Dr. Gauri Devi madam, Dr. Nivedita, Dr. Manmohan Raju, Dr. Sirisha, Dr. Preeti, Dr. Praveen Chintapanti, Dr. Sridhar Raju, Dr. Chaitanya Deepak, Dr. Pavan, and Dr. Anita, and all the people who are here for gracing this inaugural ceremony. I'm very sorry. I think we are late, but please bear with us. We have another interesting inauguration after this. With this, if I missed anybody, excuse me, and thank you, Dr. Jagannath sir. Over to you.
Thank you, Dr. George. We'll raise for the national anthem.
Anil, do you want us to sing?
Gujarat, Maratha, Dravid, Utkal, Vangu.
तब शुभ नामे जागे, तब शुभ आशीष मांगे, गाहे तब जय गाथा। जन गण मंगल दायक जय हे भारत भाग्य विधाता। जय हे, जय हे, जय हे, जय 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 हे।
With this, we conclude the inaugural function of the 6th CME of IPS TSB. In few moments, we'll start the inauguration of the Women Empowerment Committee, Samanvika State Branch, please.
Good morning. Anil, cameras. Good morning, dear all. On behalf of Indian Psychiatric Society Telangana State Branch, I welcome you all for inaugural program of Samanvika, Women's Empowerment Wing of Telangana State Branch. I would like to invite the dignitaries on the dais. I would like to call upon our President, Dr. Jagannath sir. Please welcome Dr. Jagannath sir onto the dais. Now I would like to invite Dr. Ramakrishna sir, President South Zone Branch, as chief guest. Dr. Ramakrishnan sir. Welcome, Dr. Ramakrishnan sir. Now I would like to invite Dr. Uma Shankar sir, chief guest. Please welcome Dr. Uma Shankar sir. Thank you, sir. Now I would like to invite Dr. Radhika Reddy madam online. Dr. Radhika Reddy madam, I think she has joined. Now I would like to invite Dr. Gauri Devi madam, the chairperson of Women's Empowerment Wing, Samanvika. Please welcome Dr. Gauri Devi madam. Thank you, madam. I think Dr. Shri Lakshmi madam is preparing for her presentation. Now I would request Dr. Nivedita to come to the dais. She is also part of Women's Empowerment Wing of South Zone, and she is the brain behind this. Thank you, Nivedita madam. I would like to invite Dr. Anita Raila. Please come to the dais. Dr. Anita has just become Professor of Psychiatry. Congratulations, madam. Dr. G. Preeti, youngest and most dynamic. Thank you, Dr. Preeti. Welcome. And now I hand over the proceedings to our President, Dr. Jagannath sir. Addressed by Dr. Jagannath sir.
Thank you, Dr. Minhas. Respected Dr. Ramakrishnan, President of IPS South Zone Branch and Chief Guest of today's function. Dr. Uma Shankar, Superintendent of Institute of Mental Health and Guest of Honor of today's function. Dr. Radhika Reddy, Chairperson of Samanvika of South Zone Branch. Dr. Gauri Devi, my teacher and former Superintendent of IMH and the Chairperson of Samanvika of the Telangana State Branch, and other dignitaries on the dais, members of Samanvika, Dr. Anita Rairala, Dr. Nivedita, Dr. Preeti, and my friend Dr. Minhas, ladies and gentlemen. On the behalf of IPS Telangana State Branch, Radhika Reddy garu, welcome. Dr. Radhika Reddy, welcome, ma'am.
Namaste, sir.
Namaste, ma.
Namaste, sir.
Namaste. On the behalf of the IPS Telangana State Branch, I welcome all of you to the inaugural function of the Telangana State Branch of Samanvika, the Women Empowerment Wing of the IPS South Zone. First, let me thank and congratulate Dr. Ramakrishnan, the IPS South Zone President, whose brainchild is the Women Empowerment Committee, that is Samanvika. I also take this opportunity to congratulate the chairperson of Samanvika of South Zone, Dr. Radhika Reddy. I thank both of them for accepting our request to grace the occasion. Yesterday, I was just searching for the meaning of empowerment, which means authority or power given to someone to do something. The role in women empowerment is promotion of equal participation of women and men in decision making, because women continue to have fewer rights, lower education, health status, less access to resource and decision making than men. In the last 7 decades, women have made long strides in the program, but it is very slow in the process. In IT section, they have made significant inroads. As far as medicine is concerned, women are very close to the men and in fact have dominated this field at least for the last 2 decades. But the sad part is they stop practicing after their graduation or post-graduation. But the situation is fast changing. Recently, when I requested one of the recently passed psychiatrists to work along with me, he said he can do only a part-time job. The reason being his wife is pursuing his super specialization and he has to take care of the baby at home. The scenario is fast changing as far as psychiatry is concerned. Presently, 60 to 70% of postgraduate seats, either in private institutes like Asha Hospital or government institutes like IMH, are occupied by women. Maybe in the another 2 decades, when the junior most of members of the committee, Dr. Preeti, becomes the president of IPS TSB, then the men will request her to start a men empowerment committee. Dr. Minhas told me that there are at least 70 to 80 lady psychiatrists in the state of Telangana, but unfortunately only 29 of them are members of IPS TSB. Probably the first point in their agenda should be to rope in as many lady psychiatrists as possible to become the members of IPS TSB. With these few words, I assure the state branch of Samanvika under the leadership of Dr. Gauri Devi that we are always with you for whatever you want and would like to see you growing. Thank you.
Thank you, Jagannath sir. Now I would request our South Zone President, our Chief Guest, Dr. Ramakrishnan sir, to address. Dr. Ramakrishnan sir.
Thank you, Dr. Minas.
Thank you, sir.
Thank you, Telangana branch. Thank you, Dr. Jagannath, and also Women Empowerment Committee, likely to be headed by Dr. Gauri Devi, and I see Nivedita also in the committee, I think. And I'm happy, and in some way I'm proud that this women empowerment has taken up a big lead in India, in Indian psychiatric community. So long we had only women empowerment committee in the letterpad, nothing was active. So then I decided that we should kindle the spirit of these women. So they have got a lot of potential and they can change history. That's what my vision and my faith. So 2 months back, we discussed and started this Samanvita program. And first meeting itself was a great success. One, Dr. Sunita Krishnan launched, and Professor Gauri Devi gave the inaugural lecture. It was attended by more than 600 people. Even for small meetings, for big CME meetings, attendance will be less. The second topic again was by Dr. Sunita Krishnan, but the view was different. The topic delivery, how to understand persons with the sexual violence, what do we expect, what are the caregivers of Samanvita undergo, how a psychiatrist is important for them, like that. And in the first meeting, in the first meeting itself, Dr. Nivedita was very impressed with the activity of Sunita. She has volunteered and now Dr. Sunita says, she is a very much essential component of Prajwala, her NGO. And to this March month, again, we are having a very big meeting with honoring Professor Sarada Menon, who is the first psychiatrist in India and the Padma Bhushan awardee. And we have got a topic on cyber security by an expert from Bhopal. So all these things are well organized by our Samanvi team, and the enthusiasm, the unity, the communication, and all very impressive. I hope this will be taken to the state branch of Telangana, and it is my sincere wish that every state should start that women empowerment committee. This committee is not only for psychiatrists, it is to empower community at large. We have to reach the roots of the society. And I will be happy if each Samanvika, I don't know what is abbreviation for Samanvika, how they got it from Samanvi, I don't know. Only 2 words they have added. You have to explain that. So if everyone is get attached to some NGO and help them, it is a big landmark. And gradually we can go to the roots of the society and destigmatize mental illness and so many other social maladies. That is what my understanding. And I thank the office bearers of IPS for giving us this liberty to organize all these programs. And I expect a good work from Samanvika. I wish all of them a very best and understand you are all going in the right direction. In forward, you are backed by good men. Please understand that. Both are equal partners in the journey of life. That people should understand. And according to what Jagannathan was telling, many a time, busy gynecologist, driver is her husband, who is a surgeon. So, like that, you are all empowered, but you don't take it up to the next level, to the office level, administrative level. You are all very busy, either in practice as well as home. That may be the one hindering factor for you to come up. I will be happy if some woman psychiatrist becomes president of IPS South Zone as well as IPS National. This is the wish of every men psychiatrist surrounding you. Wish you all the best. Thank you, madam.
Thank you, Dr. Ramakrishnan, sir. Thanks for accepting and coming as a chief guest. Now, I would like to invite Dr. Radhika Reddy, madam, our guest of honor, to say a few words. Dr. Radhika Reddy, madam.
Good morning. Good morning, all the dignitaries over there, and Dr. Ramakrishnan sir, South Zone President, and Dr. Jagannath sir, Telangana Psychiatry Association President, Dr. Gauri Devi Madam, Dr. Nivedita, Dr. Umashankar, Dr. Preeti, Dr. Anita, Dr. Minas, all of you. Let me thank for this opportunity given to me to be with you on this wonderful day. So as someone chairperson from South Zone Women Empowerment Committee, so I am very glad to be here with all of you. And it's a great feeling that every state is going to start this. And we inspired from South Zone Committee for this Telangana State Committee. First of all, let me congratulate all the team members, Dr. Gauri Devi Madam, who has been an inspiration to all of us, even as a student for me. So I was a great fan of Madam. And all the young psychiatrists and especially lady psychiatrists of Telangana and also Andhra Pradesh, they are always take you as a role model, Madam. And Dr. Nimedita, very inspiring, and she is the backbone behind this Telangana branch, I believe. And we coined this Samanvi with great effort. Actually, we discussed a lot to bring out this name, Samanvi. And it sounds like equality, but we are not fighting for the equality. It's not a fight, actually. So we know women or men are equal always, and we are not for the positions or other things. It is the thing that women have more roles and more responsibilities, so that they ignore certain things. They do work, but they are not for the positions, I believe. And given a chance, most of the women, they can prove themselves and they can flourish in all the fields, especially psychiatry. Because if you see, as Jagannath sir also spoken earlier, if you see all in any college, now you see in psychiatry departments, most of them are lady PGs. So in future, I think women psychiatrists may outnumber the men. But sir, I definitely can tell you that you need not require a men empowerment committee because it is all a teamwork. We all believe in that, because we are in this stage definitely because we have a lot of support from our families and our husbands, kids, everything, so that we are at this stage. I myself believe in that, and I think all successful women definitely believe in that. And coming to this empowerment committee, the activities of this committee. So what we believe is, it is as a psychiatrist, we have more social responsibility also, and we need to be aware of many other things which are happening in the society. That is the reason we came up with such kind of topics like cyber crime and trafficking and violence and all other things. And even today, the midterm CME topic, marriage and its role, and the role of our fraternity in this. So we day-to-day practice, we have to get into all these things, and we may have to consider these things, and we should be aware of many other things which are happening in and around us. So that is one thing. As a psychiatrist, we are not just a clinician, but we are having many other roles. We have to accept that, not like we have to treat the disease and give some medicine or something like that. So we are into many other things. Unless otherwise we know all these things, what are happening in and around, we cannot, it is more important for women, not only the women, we also to the men. So I came across many times that being a lady, you will understand more of a lady problems. So sometimes patients say that, and also the patient family members also express that, because she is having problem with her husband, or some domestic violence is going at home and all these things. But when what they say is, these are very sensitive matters, and women respond better to such kind of things than men. So for especially for domestic violence and other things, sometimes so the men may not react much for that, and women are more consoling, and they may have a helping hand in such kind of cases. So that is what I came to know in the past 20 years from many of my patients and their family members. So it is not that men are insensitive, but they take it in a lighter way, maybe. So these kind of programs, I think all women empowerment programs, whatever we are going to conduct or this committee, so men should attend more. These programs are not for women and for their upbringing and other things. So these are for the whole society, and men should get involved much in this. So that's what I personally request all the psychiatrists of these branches. And it is for the creating awareness among all the our doctors, not only doctors. We have enrolled many other people in this for these programs, not only our psychiatry groups, and also we are asked to get access to this link on that day for too many other students and all the things, so that everybody knows about these kind of problems going on, and then so whenever the help is required, we can attend to them. So I request, I thank all the these committee members to have a great day and giving me this opportunity. Thank you very much, sir.
Thank you. Thank you very much. Now addressed by our guest of honor, Dr. Uma Shankar, sir. Sir, from there itself. Thank you.
Good morning, all. I thank the organizers giving this its opportunity to be a guest of honor for this Samanvi. I think the Samanvi, the women empowerment, definitely. Suppose if you see at home, if a woman is given a chance, definitely she will be comfortable at home and she will be looking after her entire family. Like that, I believe that if you give the power to the women, definitely they can do the good things, and also that will be in turn help the society. So with that, I congratulate the Gauridevi madam and other my colleagues. Thank you giving this opportunity. Thank you.
Thank you, Uma Shankar, sir. Now addressed by our chairperson of Samanvika Telangana State Branch, Dr. Gauri Devi madam.
Good morning, everybody. I hope I am audible through the
Yes, madam, you are.
I would say. Yeah. I'm very glad here, and I'm very happy to be with all of you. And respected Dr. Ramakrishnan, IPS President, South Zone, and today's chief guest, and Radhika Reddy, the chairperson of Samanvi, IPS South Zone branch, Dr. Jagannath, President, IPS Telangana State, Dr. Minaz, the secretary, and Dr. Anita and other delegates, and all the other delegates who are here. I'm very glad. I'm sorry. I mean, I missed out Uma Shankar, who is a guest of honor, and he is the chairman of 6th midterm CME, and my student and my successor. I'm extremely happy, and I'm happy to be here in this occasion, inaugural function of the Women Empowerment Committee, Samanvi, of the IPS Telangana State Branch. And I'm very glad that I'm made chairperson. Maybe it's because of your seniority. I don't know how much achievements I have. Maybe at a personal level, yes. And the position I acquired, thanks to Almighty and the support from all the family members and all the men around me. I am very grateful to that. And I got the young, energetic and dynamic women, Sri Lakshmi, Anita, Nivedita, Preeti, and many women here, and also wonderful men like Jagannath, Uma Shankar, all my students and everybody, and Ashok Reddy, especially. I mean, who is very empathetic and sympathetic to the people around, not only women, but all human beings. So that way, I'm glad that we have wonderful set of people in this society to think about the empowerment of women and being here. So I'm sure I can do something about empowering women I don't think, I always think about women means not me and my colleagues. I know of number of women who are underprivileged, who are in the village, who have been struggling hard in the traditional ways of life and being oppressed, suppressed, and discriminated, harassed. I think I always think about those women. Maybe we are all the fortunate women who have achieved this position. But I think we need to do, I mean, I don't just look at profession, but I think I look at the human beings, especially the women, and under the hands of few unfortunate and angry men, I would say, or so that's the only thing. So, and I'm very happy that we are starting this IPS. Telangana branch has started the Samanvia, and we are following the footsteps of Dr. Ramakrishnan, who has started that. And I'm very glad that I have the privilege, proud privilege of being the keynote address in the inaugural function of South Zone Samanvi. So, and it's very interesting that inauguration of the Women Empowerment Committee is done along with the CME topic, the marriage and psychiatry. It's a pleasant coincidence, I would say, because women are stakeholders in maintaining marriage and making a family with the men and contributing a responsible citizen into the healthy society and to the nation. No wonder women enjoys equal right, respect and responsibility as an important member. She's equal member in the society. However, not all women from different walks of life enjoy this privilege, especially as I already told, less educated, socioeconomically underprivileged, voiceless, and many rural and a few urban women, they suffer due to oppression and discrimination. So it is the women who bring both men, I repeat again, the women bring both men and women into this world, and she can only empower another woman, because we see a lot of serials where the women harassing another woman. I think that need to be, I think we have to fight against that, the villainous women. Right? So women only can empower another woman, and she should start fighting against the female feticide, infanticide. She should fight and initiate to send daughters to school and make her achieve her aspirations in education, career, and marriage. She should raise both her sons and daughters equally as human beings first, with gender specific and gender sensitive roles and responsibilities. As psychiatrists, we know it cannot be expected with women from different strata of the society due to their different personalities, temperaments, brought up, and their life situations. But considering the discrimination and suppression and different kinds of violence against the female gender, starting from childhood to old age, all sensible and responsible men and women should work together for women empowerment. Though in reality, we know it takes a generation or two to bring the desired changes, we need to make a very sincere beginning, the persistent efforts with hope. And I believe that the routine methods, what we have been doing in imparting information about the status of women, the rights of women by lectures, debates, articles in various media, make women aware of the situation. They are already aware of the situation, but that does not give them the required support, strength, power to fight against the injustice practically at home, office, and in society. It's nice to say, we give lecture, they listen, and then they clap, they go back. But unfortunately, practically, it's not possible for a woman to really fight. Why are we agitating outside when a girl is raped or murdered? We come and say, we need to prevent much before it happens. That means we need to enter into, like social media knows everything about us. Why can't we know about the women's problems in their house, office, and start working? It's an action, it should not be lectures. I believe in that. Sometimes the disadvantaged women, they know about it, they feel disgusted, sore. We all talk, but nobody helps them. And they become complacent and they take serious steps. Like trafficking also we are seeing because of helplessness, and they attempt suicide. So these are all the helplessness, because we need to go into the practical aspects. So in addition to this, I'm not saying that we should not, we need to educate and sensitize program. I feel this is my idea that it should be more action oriented methods. They need to be evolved. And due to brevity, I'll not be going into details, but I would say that it should be practical and system approach. Being a psychiatrist, and I'm really impressed with the system approach, which is in the society. So practical systems approach in the community would be appropriate. We can have different age and different education groups with different professions from all walks of life. Could be lawyers, psychiatrists, teachers, anybody, police, the women, everybody. So with the different leadership qualities, there are few people, like we have a lot of women here who have got a lot of leadership qualities, taking up the cause of the disadvantaged women. All women, we have advantages, should take the cause, like what Sunita is doing for the women who are being trafficked. We need to use networking. Here again, I'm saying we need to have networking, collaboration, and collective work strategy. And these groups take up educative, promotive, preparatory. We need to prepare the women for the, the conflicts, the problems. And we need to be advocative for those people. And also assisting and helping them at crisis with our physical, moral, and legal support for the women in distress. And finally, rehabilitation wherever it's necessary for their dignified living after this problem. And I would, the methodologies, I would say that I think maybe we'll work on with our members, and the logistics can be worked out through brainstorming from our brain banks and with the committed volunteers. So with this brief suggestion, I once again congratulate CME, both IPS South Zone and Telangana State Branch. And it is going to be a momentum. A movement comes slowly, like our independence movement also came slowly, but it is only the collective effect of both men and women, because we constitute the society, the healthy society. So I thank you all bestowing your love and respecting me in this honor. Thank you.
Thank you very much, madam. Because of paucity of time, we won't, we'll directly have felicitation memento presentation to the members of Samanika and our chief guest of honor, Dr. Uma Shankar sir. I would request Dr. Jagannath sir to felicitate Dr. Uma Shankar sir. Thank you, Dr. Uma Shankar sir, for accepting as guest of honor. Thank you, sir. Dr. Gauri Devi, madam. Thank you, madam. Dr. Anita, madam. Thank you, madam. Dr. Nivedita, madam. Thank you, Dr. Nivedita, madam. Dr. Preeti. Thank you, madam. Thank you, sir. I would like to finish my vote of thanks by thanking Indian Psychiatric Society Telangana State Branch, organizing team of 6th midterm CME, as well as Samanvika, the females who have accepted their roles. Thank you one and all. Thank you all the audience. Felicitation of Jagannath sir by Dr. Gauri Devi madam. Sorry for the goof up. Thank you, sir. I won't waste much time. I would invite Dr. Rajvi to start our scientific program. Thank you.
Welcome again. Welcome again. Thank you all the dignitaries. Now we are going to start today's scientific program with the theme Marriage and Psychiatry with 3 sessions pre-lunch and panel discussion post-lunch. It is of paramount importance to discuss the relationship between marriage and mental illness in Indian scenario, as marriage is perceived to be a remedy to mental illness by many. Today's CME aims to explore whether marriage contributes to mental health problems, whether it has a productive role, what effect it has on pre-existing mental illness and its outcome in major mental illness. Should the news of having mental illness be divulged to opposite party? If hidden, does it amount to fraud? Taking psychiatric medication, do it affect sexual life, pregnancy, lactation, and next generation? Today, we have with us eminent speakers and experienced chairpersons and panelists to discuss these issues in various dimensions. Let us hear from them, enrich ourselves to serve better. With all your support, let's start today's first session with the topic, the game of marriage. I request the chairpersons to come on to the dais. I request Chairperson Dr. Anurag Srivastava Garu to come on to the dais.
Dr. Anurag Srivastava, sir, he is the professor and head of the Department of Psychiatry in Medicity Institute of Medical Sciences. He is an experienced psychiatrist and psychoanalytic psychotherapist, serving for more than 20 years and gave marital therapy for over 100 couples. Every year, he trains 2 students in mastering psychiatry and psychoanalysis. He is also in charge of OP and IP services at Medicity. He is an organizer for the movie club and organized more than 30 movies with the main focus of interest, fusion of art, science, and social aspects into the cinema.
I request co-chairperson of the session, Dr. R. Anita Garu, to come on to the dais. Welcome, ma'am.
Dr. Anita Rairiala, ma'am, professor of psychiatry at Institute of Mental Health, Hyderabad. And she did her both UG and PG from Osmania Medical College. She is an excellent academician and her enthusiasm is contagious. Her area of interest is in forensic psychiatry, recipient of Podu Chinnareddy Venkatramamma Award of 2018.
I welcome our speaker of the session, Dr. V.K. Mundra Garu, Emeritus Professor of Psychiatry, LTMMC and GH Mumbai. Sir will be joining us online. Welcome, sir.
Hello.
I request Mrs. Mundra Garu to felicitate our today's speaker, Dr. V.K. Mundra Garu. Welcome, ma'am. Thank you, ma'am. Welcome, sir. I request Mrs. V.K. Mundra Garu to present the memento to our speaker, Dr. V.K. Mundra Garu. Thank you, ma'am. Thank you, sir. I request our chairpersons to take over the session to proceed further. Thank you, ma'am.
I thank the organizers for giving me this opportunity. The game of marriage, the theme itself is very much interesting and intriguing. At the same time, it is very difficult to explain about marriage. I think none of us will be able to explain what marriage is all about. It is very difficult to explain. And people say that life is a game. So I think marriage is also a game. And honestly speaking, many of us don't know how to play the game. So I think our speaker will enlighten us with the challenges we face and how to deal with the problems in marriage and also to attain win-win situation at the end. So people say that love is blind, but marriage is definitely an eye-opener. So with this, I think sir will enlighten us. I'm very privileged to introduce the speaker of today's topic, Basant K. Mundra, sir. He did his MD and DPM. And he is a retired professor of psychiatry at Lokmanya Tilak Municipal Medical College and General Hospital, Mumbai. And he's a consultant psychiatrist at Hinduja Hospital and Sushruta Hospital, Mumbai. Thank you, sir. I request the chairperson to say a few words.
So this entire CME is a it addresses a very important topic. Dr. Anita told me that Dr. Mundra will first be addressing the normal marriage, and we all know there is no such thing. So that's going to be an interesting bedrock for the rest of the sessions. Dr. Anita also said that most of us don't know how to play the game, which is why second innings are very important. You learn about the pitch in the first innings, and second innings are important. But on a more serious note, marriage and mental illness is a complicated subject, starting from premarital issues to whether this thing should be disclosed or not, as Dr. Praveen is going to talk about, to whether the person can handle the stress of marriage, to how the medication continuation will be there, what is the interaction of psychotropic drugs with the sexual life, which Dr. Shilakshmi will be talking about. And then the legal issues regarding divorce, custody of children, which may happen. A lot of things have to be addressed. Marriage in itself is a complicated institution, and people with mental illness can have additional challenges with them. So I look forward very much to this wonderful CME, and we look forward to a wonderful opening session. I hand over now to Dr. Mundra, sir, to kindly begin his presentation. Thank you.
Thank you. I hope I can be heard.
Yes, sir, you are heard.
All right. I am an old person. I have refused so far all suggestions that I should give a talk on the net, because I don't know how to handle it. And therefore, I'm scared if it stops suddenly or my voice goes off, I will require help from the technical person, and I hope I can follow his orders. To try and keep it shorter, I will compress now because I think the program is running a little late. I'm not seeing the full slide, so I hope it's not my laptop. The slides are being shown by the technical people. Is it all right? Is the slide okay?
Yes, sir. Slides are okay. It is
okay.
visible.
Okay, I can see only half. Anyway, so let me start by saying I'm not going to talk psychiatry. I traditionally don't talk psychiatry for the simple reason I'm not usually invited to talk to psychiatric audiences. My whole business has been of selling psychiatry to other specialties. So whether it is the annual neurology conference or the orthopedic or the pediatric or whatever, the whole idea has been to let them know what we do. And in which case, therefore, the technical aspects of psychiatry are not likely to work out. Some panelists are saying, some people in the audience are saying that only half of the slide is visible, especially on the laptop, on our computers. So maybe the technical people can look at that. All right. Can we show the next slide, please? Can we have the next slide, please? Is there some problem?
Sir, can you see the slide changing? The slide is
No, I can't see the slide changing. The other people are also seeing half slide of the first slide. That's all. The slides have not come on.
We are working on that, sir.
Okay. Now, which is the aspect I have to talk about? I'm not talking about illnesses. I'm talking about what marriage is about and what could have been perhaps done about it. Now, clearly, evolution wanted that human babies should survive. We decided that we can progress or we can go forward only if babies live longer. in development, somewhere in evolution, because our brain and our tissues, etc., decided to take a lot of time to mature. A lot of care had to be taken of babies, unlike the progeny of other organisms which become independent quite fast. And therefore, it was felt that there must be support from both a parent on the female side and a parent from the male side, so that the baby can be surviving. And perhaps out of that arose this business of two people getting together and staying together to be able to make these young humans progress and therefore reproduce. And presuming that such an important thing should be reached by most human beings at a certain age when they are reproductive, it is quite surprising that why we are not trained for it. Almost everything we get trained. You get trained to be a doctor, you get trained to be an electrician, you get trained in everything. Why is it that this one thing which everybody is supposed to do, you don't train? I thought about this for some time, and rather than pointing out faults and telling people later after problems arise, this is wrong and you should do this and you should do that, I thought maybe people should be trained to begin with, to start with. And this training, how should it be? How do one? Well, one aspect of day-to-day human existence from childhood onwards is that we get trained in games. And since that process is reasonably pleasant for most people, people play games happily, people follow rules of games happily, unlike the education system where we are often unhappy about having to study. So I thought, could marriage have been trained as a game? Next slide. Next slide, please. Oh dear.
So the slides are changing here. Can you see them change on your screen?
No, we can't see the change. And as in every game, everybody has a rule. There are things which people are supposed to follow, and everybody knows what is expected. Let us see which game would be most suitable to study as training for marriage, so that we can take those rules and regulations and implement it. Of course, we are Indians, so let us talk about Indian games. Kabaddi, or Hututu, what is called in Maharashtra. What is that about? It's about two teams standing across a line. One person from one team enters the area of the other team. Sounds familiar? Very good. I think they've got something there. And then what happens? The other team, all of them jump on him, hold him down until he can't breathe. Oh, that sounds like some marriages, what happens in day-to-day life. But perhaps that's not the ideal thing that we want. We don't want people getting this one person who has come from the other side and is vulnerable. So no. Kabaddi is not the game that we want to train for marriage. What about Kho-Kho? Bunch of people sitting in a line and somebody runs between them trying to escape being caught. And this whole bunch, one after the other, tries to catch this person and make him out. Very familiar in some marriages. No, not something that we want done. We don't want this whole team sitting there waiting when it's my turn to catch this person. Kushti. Next slide. Clearly, many marriages are kushti. The whole purpose is two people get together, and the bottom line is one has to fall down. Not something. I don't think Indian games are training us for good marriage. Next slide. Next slide. Next slide. Boxing two people getting exhausted, as this one shows, is something that what happens traditionally. Many marriages like Kushti are boxing. The purpose being, I will be the winner and you are knocked out. Not that we want. Next one. Next slide. All right. This is a lovely game, tennis. Two people, one serves, the other hits it back, and then one tries to hit it back, and then the other person hits it back. It seems somehow that many marriages are like this. The purpose being, if you do something to me, I will do it in return. If you say something to me, I will say something in return. The winner is the one who gets the last shot in. No, don't want it. Next one. People who are all alone on their cycle. They are married, they're supposed to be together, maybe with a backseat. No, one cycles off on one's own, the other person may be running after. Some marriages are like that. We don't want that. Next. Gymnastics is about another game, totally involved in oneself, contorting, doing something, trying to excel. A very individual activity, obviously not suited for marriage. So we don't want to train in gymnastics to learn about marriage. Next. Two teams armed with their sticks, rushing against each other. So it's not about a single person now. That single person only starts, but then the whole bunch from one side gets in to attack the other side and score goals. Oh yeah, we see some of this in day-to-day life. Why did your side say this and why did your side say that? And that we will support our player and we will see as a team that you can't do this and we as a team will score. There are always two teams, not that we want. Sorry, next slide. And exactly the same. Somehow two teams clash. Why did they get together in the first place? Why don't you just have one team which puts the ball in the goal? Why do we have to have the other team? The idea is we want the other team whom we can punch down, whom we can jump on. It's remarkable for a sport to be like that. Definitely don't want marriage like this. Next. This could be one form. Usually in these competitions, there is a person who gives instructions so that everybody can row at the same time, a coordinated activity, an appointed leader who gives instructions and everybody follows, and the boat of life goes on nicely. The trouble is, as seen on the forefront, that sometimes all instructors, all people who are captains and ordering, and only one person who is rowing. Perhaps not the exact thing that we want in a marriage. Next. Cricket, what can be called, though it isn't, our national game. Let's think about cricket a little. Because it is such a popular thing. Most people train in it in India because almost all kids play cricket, even if they don't play any other games. Even if they do play, cricket is one of the primary sports. And here I would like to talk not of one-day cricket, which is a recent invention. Definitely not day-night cricket, which is again a recent invention. And not pink ball cricket. Let me draw your attention to test cricket. Because that is something that is an ideal that is held up to and everybody strives to be a test cricketer. So what are the rules and regulations of test cricket? Next one. For test cricket, I want you to think therefore of the era of Sunil Gavaskar, and test cricket, not of today's who are waiting for one team, one person to come and bowl, and the whole idea is to whack him as much as possible. Next slide. The training in test cricket, when you hear the old commentators, they used to tell us, play straight, be careful where the ball is pitched, don't flirt outside the off stump. Why? Because you are likely to nick the ball, you are likely to be caught in the slips. One of the important things that one does learn in marriage, that if you follow this rule, stick to playing straight. Don't flirt outside the off stump. I think that we need to understand these rules of cricket so that we don't make mistakes in playing, so that we are able to score comfortably, so that our scoring is appreciated by both the public as well as the other team. Next. This is something that we try to recall, not one-day cricket, because marriage is not one-day cricket. Marriage is like test cricket. And this is where, if you try and remember the old matches, West Indies against India, and those big bowlers running from the boundary line and thumping the ball hard. And Sunil Gavaskar leans back and lets the ball go. The idea being, you don't have to hit any ball. You can go on letting the ball go for the whole over. Nothing happens. The bowler goes on staring at you, but he has to still go back again to the boundary line to come running in, thump the ball, and you lean back and let the ball go. Cricket teaches you letting the ball go is not something bad. Letting the ball go is part of surviving. Letting the ball go is part of the game. That is how you can wait until you get a ball which is worth hitting. Unlike tennis, unlike badminton, unlike table tennis, where you have to whack as soon as you are confronted. Here, you don't have to. Let the person exhaust himself, herself, and occasionally slide them forward, play a stroke, get a few runs. Something about this game which teaches us, yes, maybe if we train this way, we may handle marriage a little better than a whole bunch, a whole family confronting the other family, football, jumping on each other and trying to score points against other, hockey, or somebody just lost in their own cells and to hell with everybody else and going on their own path, like the individual games that you have, cycling, etc., etc. I think cricket has got some points which is teaching us, training us, let the ball go. Next one. Another thing in cricket, you watch the matches, old matches, when a batsman made a good stroke, when the batsman scores a century, when the batsman performs well, even the opposite team claps, registers, tells him, well done. When the match is over, they shake hands and pass by each other respectfully, in a friendly manner, letting the other person know that, yes, I appreciate what you did. You won, but I appreciate what you did. Let's think about this. It would be useful in marriage. And walk. Don't wait for the umpire to say you are out. If you know you are out, just admit you're out and go. Sportsman spirit. Today, of course, now naturally they're going to third umpire and fourth umpire and fifth umpire and play it again and play it again and play it again. But in test cricket, it was respected. Walk. You know that you're out. Don't wait. Don't cheat. Don't imply that unless the umpire finds me out, I'm not out. Next one. They used to tell us in Test cricket, it's all in the head, which means that when I confront this situation, I have to think, what is this bowler doing? Where is he bowling? Why is he bowling in this direction? Is the pitch turning? Is it in my favor just now? Is it somewhere I have to be defensive? Is it somewhere that I have to play straight? And if the head is not working well, the batsman make mistakes. The coach often tells the batsman, play your natural game. Don't look at the scoreboard. Don't look how many runs you are scoring. Play your natural game. Don't go on remembering your past mistakes. Oh, last time I did this. I tried to hook and I got out. Play your natural game, which means basically don't carry your previous innings experience to the next. When you have been threatened by a fast bowler or fooled by a spinner, and you hold it in your head, and in the next match, again, you try and defend against them, you might make a mistake. Don't look at the scoreboard. Don't think of the past. Don't go on worrying what happened. Just play this naturally. Next. Certain rules which everybody must follow in cricket. That you can't do a no ball. If you do a no ball, that means you've broken some rules. Not allowed. You can't throw the ball. No intermediate bowling. There used to be a bodyline bowling series. Bodyline bowling was where these fast bowlers used to be thumping the ball in the direction of the batsman, aiming at the leg stump and hitting batsmen. You can't have excessive bouncers. You can't have bodyline bowling. This implies that though it's a game where you try and get each other out, there cannot be aggression beyond a certain line. One has to stick within that pattern, within those rules. One can't break these rules because then it's not sports. Next. One aspect that we do respect, in the dressing room, the team talks to each other, discusses everything, but nobody is supposed to talk to the opposite team member about what's happening in the dressing room. It's a very important rule, respected. They smile each other, talk, they are courteous, they are kind. But what is happening in the dressing room stays in the dressing room. A very important issue, that you do not dig what's happening in your dressing room. What did your papa say? What did your mummy say? Stick to the ethics of cricket. Something that we need to learn in marriage. Next. One aspect in many marriages, and which unfortunately is promoted very much in your sense of self. Accept me for who I am. This is who I am. It's not what you do in cricket. I am this kind of bowler. Mangta hai to theek hai, nahi to nahi. I am a batsman who hits. Mangta hai to theek hai, nahi to nahi. No. I have to adapt. Accept me for who I am is one of the laziest things that human beings can be. We need to be able to be something more than who I am. That is nothing so arrogant as saying, this is who I am, this is how I am, mangta hai to rakho. We need to change according to circumstances. We need to adapt according to circumstances. I don't take crap. Huh? मेरे से टेढ़ा बोला ना, मैं सीधा देख लेगा. Don't talk loudly to me. If you want to ask something, do it patiently. I want things on time. I can't have your mother talking to me like this. I can't. I cannot tolerate anybody shouting. I know. Live according to the pitch condition. Live according to the bowler's variation. Today, this bowler is really spinning the ball. Okay, let's wait. Let's go slow. Let's adapt. Next one. one aspect that we need to learn is what the other player is all about. And here, very much because communication is so important in marriages, we need to know what the other spinner is, the fast bowler is, the batsman is. He's a hitter, he's a middle order batsman. This one is a slow opener who blocks. We need to know what the other member is. For example, it is well understood in communication, men communicate to solve problems. Women communicate to share problems, which is why men talk very little. Because either they will solve all the problems or they must be having the value to be able to ask somebody to solve the problem. Women communicate, which is why they live longer. There are going to be far more widows than widowers in most communities. We can see that in many countries. Men are great, self-confident, complete in themselves, don't require any help. Women talk. Now, when men and women get together, need to understand what the other is and to be able to therefore communicate and share correctly. Bank employee, a male bank employee goes to work, comes back in the evening. The wife asks, how's the day? What is the day? Routine. Customers came, we do our job, came back. What do you expect in the day? What am I going to do in the bank? A woman bank employee goes to work, comes back in the evening. Husband doesn't even ask, but she says, you know what happened today? Mrs. Patil, she came in this bright red sari. Why? This is a workplace. She said, no, lagna hai na, there's a marriage, I have to attend after going. So I thought I'll just dress up from here and come on. That woman, I tell you, she just wants to show that she's got a new. Now, nobody who is a male would have thought, what is the other person wearing? Why is the other person wearing that? And even if they are wearing, okay, there must be something. Women share, women talk, women communicate. A woman tells her husband, those boys in the corner, they make remarks and they comment and all. They're really ullas have come in our area. Men will respond. 1 minute, I'll go and see. Who are they? No, I'm not telling you to go and see. I don't want to get into. I'm just telling you. The next response from the man will be, you are the one who's at fault. You dress up like this now. That's why those people come in. This is the whole problem about solving instead of sharing. That one could say, yeah, it's a major problem, which is what another woman would say. That if a woman says that these boys in the corner, they pass remarks, the other woman would say, she na, nowadays no culture. I don't know what they are taught in school. Really, guys are becoming, which is all that it is. How is your worker maid at the house? Just comes late and just want to work and she's totally lazy. And the other one will say, yeah, even mine has become like that. These people nowadays have become very overwise. It is to help express an emotion, share an emotion, relieve anxiety, to be able to be comfortable. We need to learn this of the other player, the other team, that this is a good point. Not stick to it. What is women go on talking, cut all the time, everything they have got to discuss. What is there to discuss? Men will discuss cricket. Men will discuss politics. Where they have nothing to do, they'll have an opinion. Women will discuss that which matters. Women will discuss to be able to share and relieve an emotion. Women will discuss to help each other and to communicate. I listen to you. I care for you. I would like to know what's happening in your life. Next. Often the coach teaches, learn to play the game, do your best, learn the technology. It's not just about winning. Something that we need to understand in marriage. It's not about scoring every run. It's not about scoring every point. It is being able to go through that test match and survive. Everyone making a comment, making a remark, fighting, insisting, forcing. It is a long process. Don't focus on finishing the match in 2 days, because then everybody's unhappy. Let the match go on for 5 days, play it slowly, respect that this is something that we have to wait for some length of time. Next. Next slide. So, to cut a long story short, the idea is training for marriage is perhaps necessary to be able to learn how to help each other go through this system, how to be able to survive, what rules to follow. 30 साल पहले मैं घर में शादी करके आई थी, मालूम है मेरी सासू ने क्या कहा? तेरे बाप को अक्कल नहीं, बेटी को ऐसा भेजते हैं. I listen to the story and I go on writing the history. At this age also, I do write the whole history, page full. I write it so that I don't have to look at the patient all the time and go on producing a response. Oh yeah, how interesting, really sad. I'm tired now. So I go on writing. And having written, I then raise my face and say, बहुत होशियार, बहुत समझदार आपकी सासू, नहीं गवार अनपढ़. फिर भी उसकी बात याद है. अब कैसी है सासू? नहीं, वो तो मर गई. मर किधर गई? खोपड़ी में बैठी है, खोली देकर रखा है, भाड़ा नहीं, कुछ नहीं, परमानेंट टेनेंट. We teach when they come to us about deleting, about getting rid. नहीं तो फोन का मेमोरी भर जाता है. All kachra messages keep coming. Happy New Year, Happy New Year, Happy New Year. We delete. We somehow don't. We are not trained to delete. We will be entering a relationship where lots and lots of things will be happening. The memory stores will get packed. 30 साल पहले मेरी सासू ने क्या कहा था? I asked them कि अभी थोड़ा मेमोरी टेस्टिंग करेंगे. स्कूल में टैगोर का कोई पोएम था, नेहरू का कोई लेसन था, गांधी का कोई स्पीच था. ठेंगा याद है? न टैगोर का याद, न नेहरू का याद, न गांधी का याद. 30 साल पहले सासू क्या बोली वो याद है. मतलब क्या पदवी दिया है, above गांधी. This whole business of training for marriage की नहीं बाबा, उसने बोला भाड़ में गया, उसने बोला कोई बात नहीं, उसने बोला उसका केमिकल बिगड़ा है, उसका नॉरएपिनेफ्रिन सेरोटोनिन का ठिकाना नहीं है, उसका डोपामिन बढ़ गया है. To be able to respect oneself by not having to respond continuously to somebody else's product of the brain. In every aspect of life, if we were to pick up those hints and apply it to marriage, दो गाड़ी जा रहे और some scooter and left से overtake किया, next signal तक दिखता नहीं क्या, कहां से चलता है, कौन आता है, कौन लाइसेंस देता है, कौन लगता है अपना, जमाई होने वाला है क्या? Why are we making him a better driver? Free of charge, free advice. I never give free advice. You pay fees, then I give advice. Why is it that anybody can provoke me? Why is it that anybody's statement hurts me? Why is it that I'm so vulnerable? Why am I a TV and everybody has a remote? This one presses the button, I'm red. This one presses the button, I'm blue. Freedom is कोई भी remote दबाओ, मेरे को फर्क नहीं पड़ता. Some training like this needs to be given for marriage, for all relationships maybe, that we are not vulnerable to every change, every thought, every emotion. That guy on the scooter who overtook on the left is gone. But for the next 15 minutes, my face is red, my hand is tight on the steering wheel, and I'm only talking about him. अपने देश में ही होता है, अब्रॉड होते हैं तो अंदर कर देते हैं, अपना पुलिस कुछ देखता नहीं, खाली हफ्ता खाता है, इनका क्या चला है, कैसा. फैमिली विल से ऑल्सो, जाने दो ना, क्या फर्क पड़ता है, अभी गया. ये जाने दो के कारण अपना देश ऐसा है. What had happened? Somebody overtook. One could have another response. हो सकेगा गरीब आदमी ड्यूटी पर हाजिर होना पड़ता होगा, जल्दी जाना, अपन तो सेट है, पहुंचेंगे तो पहुंचेंगे. The approach, the way we respond to events is based on this training, how vulnerable we are to provocation. Which is what कि किसी ने bumper first ball मारा तो next ball तो मैं मारेगा. No, next ball भी जाने देगा. Friends, one can go on this topic a long time. There is plenty to train before we marry. Plenty to train to realize that this is a long process. Plenty to train ki Baba, the partner is not the same as me. That I need to understand what training the partner has got, what background the partner is from, and to be able to accept, chalega, theek hai, koi baat nahi. But there is something like right and wrong. No, there is no right and wrong. It's all adaptation. In every aspect of life, there is adaptation. Mumbai weather, except for 2 months, it is miserable. You are wet, either rain or sweat. We adapt. Mumbai is working hard. It is always chock full of people are traveling, packed in trains, packed in buses, rushing to work. Nobody is sitting at home. Nahi, barsat hai aaj. Nahi, aaj bahut garmi hai. Adapt. We learn to adapt to Mumbai weather. We learn to adapt in marriage. Some basic rules, some basic statements, some basic issues, if we are trained better, if we are not vulnerable, if we are not TVs being controlled by remotes, if we are not carrying systems, how could somebody do this? How could somebody hurt me? If we are able to sit and wait and accept the other brain's chemistry, maybe marriages will survive longer. Thank you.
Thank you, sir. It's indeed a wonderful presentation and very interesting. You made it very interesting. So finally, I myself got convinced that definitely marriage is a game. Even if we accept or deny, we are in the game. So it is better to learn the rules and then follow them. Thank you, sir. Can we take up questions?
So people who are with us digitally, virtually, can type in the questions in the message box that will display here and we can take. People who are here on the floor, it's open for questions. If you have anything to ask, comment, express your views on, please go ahead.
Hello, sir. This is Dr. Nivedita. It was wonderful presentation, sir. Thank you for presenting it so interestingly. It shows how much you love cricket.
We don't have a choice as Indian males.
Yes,
that
sir.
is the only language we know. That is the only sport we know.
And really appreciate that men talk on issues which they have nothing to do on, and women share. That was well appreciated. I really thank you for that comment. I just wanted to ask one thing, sir. If we have to be so unresponsive, so neutral, and so composed in a marriage, why to get married at all? If I have to be so composed and have a personality so independent that I'm not affected by anybody, I can be by myself.
Yes, we can. Yes, we can.
When someone asks when they come to you, when I'm not supposed to be emotional, I'm not supposed to be reactive at all, why should I at all go for a marriage? I am happy by myself. Is the youngsters who come in keep telling when we teach them or when the family gets us to them in the initial phases of their marriage, that we have to adjust, we have to, adapt and all these things, advices when we give the youngsters, most of the youngsters come up with this bouncy question to us that why should I at all get married when I have to do so many and compromise on so many fronts? What would be your advice?
One, that we have to bring up the next generation with support with somebody else. And two, we ourselves are going to need, whether it is companionship, somebody to look after in illness, somebody to help us. It is nice to have a committed partner. It is nice to maintain this support for oneself. Purely selfish motive. You do savings, you put in fixed deposits. The idea is this should help me later. You don't put in a fixed deposit key, I'll get just now something. It is going to come after 3 years. Your PPF is going to come after 15 years. The idea is we all have to invest for survival. Who is going to help me? Brother, sister, parents, they won't be there. I need a partner for me. I need a partner for communication. I need a partner for sharing. I need a partner I can depend on. I need a partner to bring up my next generation. My genes must continue. So this whole business has come about as part of evolution. Human beings learn कि ये करेंगे तो best है, ये करेंगे तो survival is better.
Good afternoon, sir. I am Dr. Manmohan. I have few questions to you, sir. Before that, I have two sentences in Telugu with your permission. మొత్తం టాపిక్ అంతా విన్న తర్వాత సార్కు క్రికెట్ ఇష్టం అని తెలిసింది కానీ అసలు ఎసెన్స్ అంతా మర్చిపోయినట్టున్నారు మేడం సమన్వయ్ గారు. రెండోది, men are to solve the problem and women are to share the emotions, what you said. And men also like to share their problems or emotions with other men during that evening hours or restaurant or bars. Women should allow for that. And my question is, that is only comment, sir. And my question is, do you think in any way the female education is causing inappropriate methods, the causing more problems in nowadays younger generations, especially 90s kids and 2000 kids are facing more problems when compared with older generations and 2010 kids. They have clear ideas, older generations have their clear ideas, and 2010 after kids are around the age of 10 years or 11 years, they are having clear ideas. Is it the education system or especially increased female education causing the problem in marriage? Please respond, sir. Thank you.
People who believe that they can independently survive may not want to adapt to a marriage-like situation. It is foolish to think that just because one can earn, one can survive. One needs, as our branch is all about that it is not that one can manage to get money. We need emotions, we need support, we need security, we need commitment. So education which does not teach that or which undoes that or helps people to feel that I'm able to look after myself, why the hell do I want a partner? Not very likely to be useful. What was the other question? I'm not sure, perhaps I didn't get it. But men share is true. It is not that men don't share. Men share only after being drunk. They'll sit down in the evening with their glasses and then they will talk nonsense. Otherwise, in day-to-day life, in complete sobriety, a man may be having great problems or got to break up with his girlfriend, but he won't mention it to the girl. Whereas a girl will mention everything the boyfriend has said. You know what, today it's a rose day now, so he's supposed to bring roses now, but he didn't. So I just didn't talk anything. I just said, like say hi. He doesn't understand what's wrong with him. Now, Rose Day is not a collapse, but by communicating that and getting an answer, yeah, guys are like that. I mean, nowadays, somehow they're all just preoccupied. They want only one thing. One has communicated, shared, and resolved. Men share when drunk with other men who are drunk, who will give advice of drunk men. छोड़ दे उसको, जाने दे, ये लोग को कुछ नहीं अक्कल है, अपने को नहीं सोचने का. Men will have to learn, then they will be able to survive longer. Otherwise, the expected male age of survival is always going to be lesser and lesser and lesser than a female's age. Women should teach men this so that we don't have so many widows. Any other question?
Good morning, sir. So myself, Dr. Madhur, I'm third year resident from Institute of Mental Health, sir, Hyderabad. Sir, I have a question that you said one of the person has to, like, both of them have to take it silently and have to understand each other. But what if on one end is say Hardik Pandya and on the other end is Rahul Dravid? Like if one partner is very aggressive and other partner is very understanding, then how does that situation change? Does the understanding person have to tell the other person that take it lightly and adopt? How to make it happen?
That's
Because if a
where we
partner-
come in. अपना धंधा कैसे चलेगा if people are all going to be perfect? If people are all going to behave nicely and behave correctly and do everything properly, then where is our business going to be? Please, please, please. We need to educate people, but not make them perfect so that we survive. We have a vested interest in people quarreling, fighting, getting upset, and please come to me. Then I will be able to help you with these fees. Itna paisa do, madad karega.
Thank you, sir. Thank you so much, sir. As a resident, I think it will help me a lot, sir.
Yeah. Okay.
Sir, I'm Dr. Sri Lakshmi, and I just had a compliment to give, sir. One line per slide, such terrific symbolism, and the way you have presented, I really bow down to your presentation, sir. And unfortunately, I concluded that the game played in my house is kabaddi with my husband as a victim.
I do want to say that sometimes one may feel that this is a scientific conference and don't trivialize these things and don't take it so. Maybe we should not take ourselves also so seriously. I mean, it's all very well about NMDA and what new receptors are found, and it is now all about GABA. But in day-to-day life with human beings, maybe this kind of area for even doctors, for even psychiatrists to be able to see and train people, because we have limitations of how much we can handle serotonin. Maybe we can train people or help people see so that they can handle their own serotonin. Anyone else?
Thank you, sir. It is indeed very wonderful presentation, sir. Very thought-provoking, and you made it very witty, and we enjoyed thoroughly, sir. So thank you so much for actively participating in this session. We'll end this session now. Thank you.
Thank you. Thank you.
Thank you, Dr. Mundra Garu, for the wonderful insight into the game of marriage. I request Dr. Mayurnath Reddy Garu to give the memento to chairperson, Dr. Anurag Srivastava Garu. Thank you, sir. Thank you, sir. I request Dr. Sirisha Garu to give memento to co-chairperson, Dr. Anita Garu. Thank you, ma'am. Thank you, chairpersons, for moderating the session. Thank you so much. Now, we are moving on to the second session with the topic, to tell or not. That is the question. Eternal questions with potential litigation. I request chairperson, Dr. M. Ramasubba Reddy Garu, to come on to the dais.
Dr. M. Ramasubba Reddy, sir. He is the professor and head of the Department of Psychiatry at Institute of Mental Health, Hyderabad. He did his MBBS from Kurnool Medical College and MD in the field of psychiatry from Osmania Medical College. He is an experienced doctor and ardent professor in the field of psychiatry, serving for more than 25 years.
I request co-chairperson, Dr. P. Chaitanya Deepak Garu, to come on to the dais.
Dr. P. Chaitanya Deepak, sir, his current consultant psychiatrist, director, Asha Hospital, and he studied MBBS from AVMC, Pondicherry University, DPM from SVS Medical College, and MD, NRI Medical College, and his areas of interest are emergency psychiatry and OCD.
I request Speaker Dr. Praveen Kumar Chintapati Garu to come on to the dais. I request chairpersons to take over the session. Thank you, sir.
Hello? Hello? Am I audible? So today's topic is to tell or not to tell in the marriage. This is an important topic. And most of the times, marriage is an institution where two individuals unite from different backgrounds. In the process of natural selection, everyone wants to marry healthy individuals, both psychologically and physically. So no one is ready to marry the psychiatrically ill patients. So when the parents asks about the illnesses, whether we have to disclose about the illness or we have to conceal about the illness, naturally the psychiatrist will tell, you have to disclose the illness. So the next answer is, if you disclose the illness, no one is ready to marry. This is the biggest problem. So for small illnesses like anxiety, dysthymia, conversion disorders, for all simple illnesses, so nothing wrong in disclosing. So there are incidents, there are cases where the spouses were abandoned or had been prescribed for the psychotropic medications for such simple illnesses, anxiety, dysthymia, and conversion disorders. In that case, the role of psychiatrist is important. We have to convince the individuals and their parents regarding the illnesses, and we have to educate them. So by that, we can overcome the stigma or negative feedback regarding these psychiatric illnesses. So even in court of law, there is a lot of sanctity for the Indian marriage system. So we need to protect the sanctity of the Indian marriage system. That's why we have to educate properly. So in this process, we get a lot of queries, how to deal with the in different situations. For that, Dr. Praveen Chintapati Garu is here. He is an excellent speaker with good knowledge and oratory skills. Now I hand over to the co-chairperson to read the biodata.
So it's always a question whether to tell or not to tell, but irrespective of what we tell the patients, it's always ends up they take whatever they want to. That's what I have seen. And I hope that Dr. Praveen is going to enlighten us about this, like how to handle the situation. Dr. Praveen worked as a consultant psychiatrist at NHS UK, and before that, he pursued his studies from NIMHANS from 1994 to 1997, Bangalore, and Usmania Medical College, Hyderabad. During his 12-year stint with NHS UK, Dr. Praveen honed his skills of understanding human behavior and the mind from various perspectives. He explores life on a different spectrum and sees things through his lens, a view that finds beauty in chaos. He worked as a research fellow for Liprosidone trials at this very institute, IMH. He has super specialization in constellation liaison psychiatry. Dr. Praveen is currently working on artificial intelligence in psychiatry and allied fields. He has recently conducted a workshop at IAPP Mumbai. He enjoys farming, grows vegetables and fruits in his leisure time. A relentless learner, Dr. Praveen, through his professional and personal understanding of the basic tenets of human behavior, is at its core. He approach to defining and achieving transformation is not only unique but also challenges many existing. He hosts the various talk shows and well-being coach and transforming change agent. I hand over to Dr. Praveen to take over the session.
God, that's a very, very lengthy introduction. Thank you, Chairman Dr. Bharati Garu, Dr. Chaitanya Deepak. I thank organizing committee chairperson, Dr. Umashankar Garu, Secretary George Garu, and Minhaj Garu for giving this fantastic opportunity. I'm grateful for this beautiful idea to be discussed and shared. I am not going to bring in any wit. I don't have any jokes about marriage. And neither I'm going to get into a bit of wife bashing or husband bashing or marriage bashing scenarios. So it's something which I am very passionate about, especially marriage in the context of an Indian society with heritage of millennia, which gets so ingrained in becomes part of a basic genome or a genetic structure. If, as Dr. Mundra said, if the gene is selfish, we are mere containers propagating genes. So Richard Dawkins, it's not my thought, Richard Dawkins, the selfish gene. So I start with this interesting quote. Kimaswin sakha grahaste sadha. Who is the friend of a grahastha forever? This was the question posed by Yaksha to Yudhishthira. Yudhishthira Dharmaraja, when all his brothers were lying in unconscious by the lake where Yaksha was there, this story everybody knows. I picked very specific questions which pertain to relationships, marriage, and psychiatry as well. So, Kimaswin Sakha, who is the friend of a grahastha, a married person? Grahastha is the dharma which everybody has to undergo. So, who is the friend? And Dharmaraja replies, Bharya Sakha, Grahaste Satha. Wife is the friend forever for a grahastha. And then the next question was very interesting. Then, who is the Sakha for the person who is dying? Take a guess. And Dharmaraja says, a physician is the friend for the person who is dying. So that's where we fit in. So it's an integral part of human mind, which has been consistently put into our narrative, an Indian narrative which has been told as a story, which we have imbibed into ourselves. And then, Yaksha goes on asking further questions like, oh, who's the person who's heavier than the heaviest of most things, like heavier than earth? Then Raja says, mother is the heaviest person in the whole universe. She's heavier than earth. Ah, then who is heavenly than the whole heavens? Father is the most heavenly person than the heavens. Ah, then which is the fastest thing which happens in the world? Mind is the fastest thing which happens in the world. And what is the one which is more numerous than the grass on the earth? Dharmaraja says, it is the thoughts which are more numerous than the grasses on the earth. Ladies and gentlemen, and my friends who are watching online as well, I don't have many slides though. This idea of marriage or union or joining together has never been separated from mind ever, any time. And the life of a grahastha or a married person and marriage in itself has never been isolated or seen out of context of existence of human being within Indian culture and marriage as a ritual. Can I get the next slide, please? Marriage as a ritual has been an essential part of existence and part which everybody has to undergo. Wherein I cannot find English words, I'll use the words which are used in the local colloquium or Hindi. Pelli, marriage as an event, Pelli anedi tantu. It is an act. And people give this huge thing. Dharmaraja had a huge problem. Like, if he gave a wrong answer, he'd have been dead. If we as psychiatrists give wrong answers, we might end up talking to the judges in the courts. So that's the worry of litigation. That's what I was telling, to tell or not to tell. And the next thing was what to tell actually, and when to tell and how to tell. That is the question. And how much to tell is the question. So when it comes to marriage as an Indian tradition, it is an essential part of our Indian psyche. And when I have taken this very beautiful example, which is part of human psyche, especially the Indian psyche, The wedding of Shiva Parvati is considered to be the ideal wedding whichever happens. And this beautiful wedding is, consecrated by Brahma himself. Vishnu gives away the bride. And giving away the bride has a very beautiful meaning, both in Indian and Hindu-Indian context as well as Islamic context. There is a process. Kanyadan or the wali in Islam gives away the bride, the guardian, the father who gives away the bride. Here, Vishnu gives away the bride, and this whole devatas, everybody is attending. And this tantu doesn't go without problems. Parvati's mother comes in, finds Shiva, and this guy is like, having serpents on his neck and has all the ashes smeared onto himself. And Menaka or Meena, she's called in different forms. She says like, I'm not going to give my daughter to this guy. बारात आया हुआ है, बाराती है, लड़की की माँ बोल रही है मैं बच्ची को इसको नहीं दूंगी. क्यों? अरे this guy, look at him, how can I give my daughter to this guy? And then of course the further ritual happens, and then there is a revelation and she faints. Like any other marriage which happens in our Indian society, there is an event, there is a drama associated. बारातियों को खाना नहीं दिया, बारातियों को ये हुआ, बारातियों को वो हुआ, लड़की वाले इतना गोल्ड देना है, लड़के वाले मिसबिहेव कर रहे, reception lo inta bettinara. This is part of the drama which everybody has to undergo, and that should not trivialize the whole idea or the beauty of marriage. I think there is always this huge drama about bashing marriage. Marriage, shadi barbaad. This wicked, ridiculous jokes which we tend to perpetuate on internet or WhatsApp trivializes the whole idea of the marriage, which within an Indian context is not just a contract. Marriage is not a contract in Indian context, ladies and gentlemen. Marriage is a sacrament. Marriage is a covenant. Marriage has a meaning which is higher. Marriage in a Hindu context, it's about like, dharmecha, arthecha, kamecha. And then there is one beautiful word which people say, nati charami. I shall not transgress. It is not that I will do this, I will do this, I will do this. I shall not transgress. And then there is another interesting bit Indian Hindu marriage says is that this sakha bhava, the relationship between wife and husband, is about sakha, friendship. And when saptapadis when people make the 7 steps, they are told sakha samvad. You walk in as friends, may you enjoy and cherish each other's friendship. You become him and he becomes you. That is the sakha relationship which is consistently put in, rather than an oppressive or argumentative or punitive or adversarial system which marriage is portrayed continuously by wicked media. And to dilute the idea of marriage as an institution by whatever reasons, by whatever forces who don't believe in the idea of marriage, there is trivializing the idea of marriage, especially of an Indian context. Can I get the next slide, please? We do have various types of marriages, which this is recognized. Now I gently slide into the legal aspects of it. We have Brahma marriage, Daiva, Arsha, Prajapatya, Gandharva, Asura, Rakshasa, and Paishacha. I'll take the first one and the last one. Brahma wedding is about like, it is witnessed, it's solemnized. There is a person who solemnizes the ritual. It need not always be a Brahmin. Somebody bigger, an elderly person is there. And then the bride's father gives the hand. Panigrahana is done, the hand is given, and Kanyadana happens. And bride's father sends the girl with her ornaments which she has with her. So there is some element of, giving the bride in her best form to the boy who is deserving, educated, deserving, qualified, and fit to be married as mentioned by the learned. So any idiot cannot get married. He has to be worth it. So that's the Brahma wedding, and then Daiva is something lesser. Arsha, wherein there is a transaction, the boy gives certain amount of money to the girl's family to get. It's considered to be lesser form of a marriage. And then you have Prajapatya and Gandharva. Gandharva is wherein boy and girl like each other, and then they decide like, we need to really go about doing things. So let's get married. And there need not be a witness. A witness could be a tree, a pole, or a sky and heavens. Dushyanta and Shakuntala get married in Gandharva Vidhi. And Gandharva is considered to be the lesser ideal forms because there are no witnesses in human form. So Gandharva has its share of problems, like Shakuntala and Dushyanta had their share of problems later. But of course, we have Bharata after that. Then the Asura. Asura is like there is aggression in terms of, giving something and stealing somebody. Rakshasa is abducting a woman. This is now, according to the legal system, Gandharva and below would be considered as marriages which should go null and void. Rakshasa is abducting somebody. Paishacha is a very bizarre thing, but I'm intrigued, but that like this persons of the past, like 6,000 years ago or further, have thought of this idea. This is a very wicked way of marrying somebody, intoxicating a woman or inebriating a woman and getting into sexual activity, thereby making that woman to get married to him or live with him. So Paishacha is considered to be a criminal offense at the current time. So the last four would not be considered as legally married situations. And I'll take you run through a few of Islamic law. Can we get the next slide, please? I will not. There are a few other wedding terminology used in Islam, but these are the legal thing. One would be considered as Sahih Nikah. If somebody wants to correct me, please do. And this is the regular nikah wherein there is a wali. Wali is the guardian or father of the person who would give away the bride, and the bride does what is considered to be kubul. She has to agree that she agrees to marry this person, and this kubul is done independently. Boy will be in one room, girl will be in another room. There is no interaction at the time, and this is mediated by a qazi. A qazi need not always, depending on the circumstances, some elderly person within the village can also oversee the ceremony. And there is a document which gets written. It's called a nikhanama. Nikhanama is like a marriage certificate. You can see one on the other side, which is being signed by the bride. So it is documented. You either get a thumb imprint, and Nikhanama is a very beautiful document. It has the name of the bride, name of the groom, father's name, and their marital status at the current time. Unlike the Hindu thing, if a person has been divorced in the past or in the period, between marriages, like if somebody has lost a husband or somebody has lost a wife, or if it's a third marriage, it gets documented. So Nikhanama is a very valid legal document which Islam proposes. And then there is something called Batil Nikah. Batil Nikah is something which would be considered as a void marriage, wherein somebody marries somebody outside the Islam. Like if a man marries a woman outside the Islam, but she's not converted, the marriage would be void. Or if a woman marries somebody outside the Islam, so that would be batil, or it would be considered as a void marriage. And then you have fasid nikah. Fasid nikah is something which is on the borders of judgment, wherein in a learned manner, ulema can interpret whether it's the right marriage or not. Somebody marries a fifth woman. So would that be fasid nikah? Like, it could be on the borders of right, wrong, those sort of things, which leads interpretation. Or, somebody who is in the process, like, period of iddat. Iddat is somebody who is divorced and she's supposed to get married to somebody. If somebody is within that period, if she gets married, that would be something like a fasid nikah. And then you have mutanikas. Mutanikas are no longer valid. Mutanikas are the marriages of convenience, which we hear in the newspaper regularly, that people get married just to have a contractual marriage, to have sex or intercourse within. We do hear that, and mutanikas are banned in our country. So these are various marital arrangements which are seen. And traditionally, if you look at the ideas, though Islam has lots of Arabic and other influences, but there's a very Indic concept about it, very Indian peninsular concept about it. And there is a tradition of identifying married women with certain way, certain ritual, and married man with certain way and certain rituals and certain responsibilities. So the Indian subcontinent, peninsular India, has a very beautiful understanding of marriage, and that shall not be diluted or trivialized when it comes to a case room consultation or a clinics. Can we get the next slide, please? I'll take you through scenarios. Please do, Chairman sir, whenever you want me to stop, I'll stop. Scenario one, These are absolutely from my practice. There might be identifiers which are changed and the stories are a bit, cooked up so that, we cannot identify these individuals. That's the only reason, but these are from my practice. I was sitting in my outpatients clinic. Two young people come with their respective families. And one of the families is very popular, big political family. They came in and then said, like, Dr. Gari, my anxiety undindi okappudu. This girl was going through some anxiety. And we just want everybody to sit together and then say, like, we just want to get over with it. And the boy walks in and the girl walks in. And as soon as I saw the boy, I remember the boy. I saw him in another hospital. And he came to me with his partner, gay partner, and that he's gay. He's not bisexual, but he's gay. So what do? Do I tell the girl's parents? Do I tell the boy, like, kya kar raha hai yahan pe? Do I recognize him? Do I acknowledge that I know him? Do I say, like, bilkul anjaan behave karu? Do I say, like, all right, this boy, he is gay, and why are you giving your girl to this guy? And boys' parents don't know that this boy is homosexual in orientation. So what do? I'll come to that. Let's go to the next slide for a second, and I'll probably revisit this slide again. This is about Mr. X and Hospital Z. Mr. X, this is online available, indiakanun.com or indiakanun.org. All law documents have this. So there is no confidentiality on that. Some of the journals have their names as well. So Mr. X is related to a minister in Nagaland. He goes to Chennai for some routine investigations and all. And then the hospital in Chennai says, oh, there is another surgery happening. Can you donate blood? So Mr. X says, fine, take my blood. And then he gives. And the blood wasn't used. It was donated. He donated blood and everything went on. Blood wasn't used. And then it turns out that Mr. X has proposed one Miss Y in Nagaland. As soon as this news was out, somebody from the hospital calls up the minister and says, how can you get your girl married to this person? This guy is HIV positive. Now, the biggest issue is, did the hospital breach privacy? Was it the responsibility of the hospital to actually tell that to the person? And did hospital breach the core essence of medicine, wherein when we take Charaka oath or Hippocrates oath, we say, like, I shall hold it in my heart till I die, of the weaknesses and the vulnerabilities and the, whatever I see when I go enter the house of patient, I shall hold that secret till I die. Why did the hospital do that? And was the hospital right in doing it? What happens? So this guy goes to the court, says that my confidentiality is breached. Now my relatives, my whole town, and the whole people in the community know about the HIV status. I need to be compensated for that. And there's a breach of confidentiality. What do you think has happened? The lower courts held in favor of the appellant, that's the person, Mr. X. And then it went further to the Supreme Court. And Supreme Court upheld the decision of Hospital Z. For simplest reason that there is a responsibility of the hospital to protect Miss Y. The argument from the hospital was that, having been aware of the situation, there is a responsibility on the hospitals to protect. Because the biggest issue is that who is the owner of the data? We are moving into an internet-enabled and data-enabled world. And information is money, information is litigation, information is poison, information is elixir. Information will make you rich, information can throw people in jail. So in that situation, Mr. X technically is the owner of the situation, but there has been a responsibility at that time. This is 1995. This is the hospital I'm associated with currently, but yeah. This case had lots of issues addressed, and this case gets constantly quoted across. When we do release information, we are taught consistently in a postgraduate training, if the safety of other person is involved, if life and limb are at threat, or when do I breach confidentiality, we always tell. So that principle has been used here. So I'll be talking through the principles in confidentiality and the guiding documents which help us through as we go along. But in this case, the principle used was the safety of another individual and life and limb of another individual. And the next thing, what happened is this guy goes and then puts another case. By 2003, he goes and says, like, what if Miss Y agrees to marry me after knowing the status? Could court have a problem with that? We don't know the outcome of that bit of the thing, but court says it's none of our business. That's what has been agreed. People have right to make choices, whichever the way we want. But again, how much further it's been pursued, that's been the first response to the courts. Like, if people make choices, irrespective of how stupid, irrelevant, or wrong they might sound to another individual, courts have no role to intervene, because I am allowed, if unless it sounds like, I'm doing it out of depression or something like that, I go and jump in front of a train, that's a different thing. That doesn't sound like a choice. That's a suicide. But if I want to get married to somebody with HIV status, that's my choice. So court allows that choice, and that's what is considered to be Article 21, freedom to live the way you want to live and free life. So court has invoked Article 21 of the Constitution, saying that people have a right to make choices. Can we go to the previous slide, please? So what do I do? What did I do with this person? I actually was, I don't know, I was aware of the judgment that I could say that, like, not in your best interest, mat karo, this is not right. Or simply I could say, like, hey, hello, Krishna, how are you doing? Or Suman, how are you doing? Or whatever. But I didn't say that. As soon as I saw the boy, I said, this is marital work or premarital work or whatever they were coming in for, based on the telephone calls I had prior. I said, listen, mate, I can't really do this. I can suggest a colleague who can help you. And it was chickening out. I know, heart of hearts, I might have, betrayed the girl in some way. I might have not done the right thing. I might not have morally or ethically, or, she has a right to know. It doesn't mean that, and the responsibility to tell her was the boy, not me. That was the defense I was using to keep myself safe. And still it somewhere pinches my conscience that there was something which I could have done. And even if the same situation happens today, I'm not sure how I'm going to respond, because there are no right and wrong answers defined. Can we get to the next slide, please, and slide after as well? Another case scenario, 45 days of marriage, young couple, working class couple. This boy works in industrial estate in and around Hyderabad. Girl comes from a sort of, she's 12 years of schooling, intermediate educated. Working class families on both sides. This girl got married, and then both of them got married. And one day this girl supposed to have slipped in the bathroom. Nobody has witnessed it. And then uske baad, she was talking to herself, muttering to herself, smiling to herself, the regular story. And ardham lekunda maatladutundi, em jawabu istundo teliyadu. And this boy says, లేదు సార్ పెళ్ళైనప్పుడు నుంచి ఇట్లానే ఉంది, అసలు మొదటి నుంచి పడ్డకు కాదు, పడక ముందు నుంచి ఇట్లానే ఉంది. అండ్ girl's family says, పెళ్లి చేసి ఇచ్చామండి పిల్లల్ని, అంతమంది మధ్యలో పెళ్లి చేసాము, there were so many witnesses. Can anyone tell that she was unwell? This guy, he couldn't take care of his wife. She fell in the bathroom. He doesn't have the courtesy to take care. తలకేదో తగిలిపోయింది, అందుకని ఇట్లా అయింది. And you see her in the clinic, and you find something which is very rarely seen in a chronic unwell condition, which is suggestive of a schizophrenia-like illness, because we have only 20 days of history as told to the clinician. So this boy says, "Sir, చెప్పండి sir, పెళ్లికి ముందు ఉంటుందా ఇది బాగా అవుతుందా, ఇమ్మాయిని పెళ్లి చేసుకుని ఉండగలనా, నాకు సుఖం ఉంటుందా?" I told you, like, Kimaswin Sakha, who's the friend? That fellow is no longer having a friend from his point. Grahste Sadha, Hamesha ke liye dost kaun rahega? Ab uski ummeed arman pure gir gaye sir. And then this girl very coyly says, "Nenu evvaru doctor ni chodledandi." And then she's giggling and grinning in the interview as well, actually, while it was happening. And then parents are doing. So what do we do in this situation? What do we tell the boy? Do we tell, like, my clinical wisdom says that she has been unwell for many years to come? Or she has been unwell for past 10 years or 20 years, that's my wisdom says? Or I just go with the data? Just say, like, మీరు చెప్పిన దాని ప్రకారం పడ్డ రోజు నుంచి ఇట్లా అవుతుంది, వాళ్ళు చెప్తున్నారు, మీరు పెళ్లి చేసుకున్నప్పుడు ఏమి నోటీస్ చేయలేదు, బాగానే తంతు ఆ తర్వాత కార్యాలన్నీ బాగానే జరిగినాయి, సో చూద్దాము ముందు. Or do we tell, like, that, oh, this is an illness, from the sound of it, it sounds to be a very chronic illness, చానాలు మందులు వాడాల్సి ఉంటుంది, ప్రాబ్లీ జీవితం అంతా మందులు వాడాల్సి ఉంటుంది, పిల్లలు పుడితే అప్పుడు ఆలోచించుకోవాల్సి వస్తుంది, దానికి మందులు అప్పుడు ఆపేయాల్సి వస్తుంది, ప్రెగ్నెంట్ అయితే చేంజెస్ చేసుకోవాల్సి వస్తుంది, ఇవన్నీ 45 రోజుల పెళ్లిలో చెప్పాలా? సో this happened yesterday in my clinic. So what do I tell? My first response, this young boy, working class, bought a second-hand motorcycle after the wedding to take his wife around, thinking that he's going to have a good. Sir, మీరు చెప్పండి సార్, ఏం చేస్తారు, మీరు మొన్న వచ్చినప్పుడు మందులు ఇచ్చినారు, దిస్ ఇస్ సెకండ్ కాన్సల్ట్, మొన్న వచ్చినప్పుడు మందులు ఇచ్చినారు, ఈగానే ఒక వారం రోజులు బాగానే ఉంది, యాక్చువల్గా 3 రోజుల నుంచి మళ్ళీ మొదలు పెట్టింది. She got olanzapine, 5 milligrams, not massive doses, diagnosis wasn't clear. So చెప్పండి సార్, అసలు సంగతి చెప్పండి, మీరు ఎందుకు అవుతుంది ఇలా, ఇది అసలు పడ్డందుకు అయిందా, అసలు ఎందుకు అవుతుంది మీరు అంటే. And my gut reaction, by then I was worked up, spent about 25 minutes with the family. I said, ఏం చేస్తానయ్యా, మందులు ఇస్తా బాగాడానికి, అంతకంటే ఏం చేస్తాను? That was my first response. And then I took it back. I said, like, I felt I was very cruel at that time. For a moment, and then I went back and said, like, sorry, I didn't mean it that way. I actually said, sorry, I didn't mean it that way. And said, like, బాబు మీరు మొన్న వచ్చినారు, అర్థం చేసుకోనండి, ఇంకా 2-3 సార్లు చూద్దాము, ముందుకెళ్ళి ఎలాగుంటుందో వైద్యం చూద్దాము, తర్వాత ఎలాగుంటుంది మీరు, నాకు అర్థమవుతుంది మీరు ఏమడుగుతున్నారు, కానీ ఆ విషయాలన్నిటికీ నా దగ్గర ఆన్సర్స్ లేవు. I cannot give you exact, precise answers which you are expecting in terms of, could this illness go on forever? Was it existent prior to that? My gut might be saying, my wisdom might be saying, but for documentation purposes, I don't have any knowledge to pass on or give it to you, or information to give at this time to you to take further course of action. He was all right, actually. And I'm really dreading to see what should I tell when I meet this couple again in another few weeks' time. The next slide, please. So the core principles we use, Hippocrates oath, Charaka oath, we did talk about. It has a huge element of morality. Hippocrates oath doesn't allow the flexibility of, giving information out at all in any form, any day, any time. Even it's about safety, security, or whatever, though there have been modifications, add-ons, but it actually doesn't allow any information to be transgressed anytime, any day. Charaka oath has another interesting dimension. It has this dimension of, you cannot treat the people who are not loyal to the king. You cannot treat the people who are not loyal to your teacher. So there is a very strong Guru Chela Parampara which is introduced within the Charaka oath, which binds the student to the extent that you shall remain almost supplicant. That's the word. The English word is supplicant. దట్ గురువు ఏం చెప్తే దానికి జవదాటకుండా గీత దాటకుండా ఉండేటువంటి ప్రక్రియ సప్లికెంట్గా ఉండాలనేటువంటి చిరకవతలో ఉంటుంది. అండ్ ఐ షల్ టీచ్ ద ఆర్ట్ అండ్ స్కిల్ ఆఫ్ మెడిసిన్ to the person who is deserving, which is reflected in Hippocrates' oath as well. Then Charaka Oath has another interesting dimension in terms of, refusal of care. Because the modern MCI guidelines allow you to refuse care. If somebody comes in, if it's not an emergency, you can actually refuse care, except in emergencies. That's something which MCI guidelines says. Charaka Oath addresses that, but Hippocrates' Oath doesn't have a mention of refusal of care. MCI guidelines have something very interesting about right of the patient to have his data protected and the privacy respected. And the word they use is delicacy, but probably they mean delicateness. It's done in 2002. I'll just, if I can get it out, I'll read it out verbatim. So it says that, like, the records have to be kept in such a way, and there is also a need, MCA guidelines address the need for getting electronic records kept in safe order as well, and need to keep, there is no, again, mention of OP records for longer periods of time, but there is a need to keep 3 years of IP records within this document. But I urge all my colleagues, especially young people who are getting into practice, who are training and starting their practices, keep a record in some form or other. That's absolutely essential, because there is this appetite, like, I do that. Write a slip, give it away, and there is no way of knowing Mr. Mohan visited, Krishna visited, and if the face comes back in front of you again, we don't know who it is. So there is this need from MCI guidelines that you are a purveyor, you're just a guardian, because of what the word you use is fiduciary responsibility. Fiduciary is about being in a position of trust. And this is a very precarious, funny situation, medical profession, and especially psychiatrists, because I'll go to the next case reference. Psychiatric data is not like regular medical data. There has been case evidence both in RTA Commission and also Supreme Court says that psychiatric data is a special data. It is not like regular medical data, which cannot be disclosed. Psychiatric data has to be vetted many a number of times before it's actually disclosed in whatever way it is. And you have universal medical principles, which is about the responsibility of the fiduciary responsibility. That's a word. People have this huge moral obligation cast upon medical professionals, especially psychiatrists, to hold data, because I think psychiatrists are privy to much more, how should I say, not so pleasant content. We see the underbelly of the society. We see probably people who would morally be considered as not so nice people. We see dissocial personality people who might have done most horrendous things in their lives. We see prison wards which have criminal histories of very unpleasant and gut-wrenching nature, which we see pedophiles, we see very unpleasant people. But that data, society expects you to keep it private, and at the same time expects you to disclose it to special people when it's right. And this ambiguous communication, which is constantly fed into our colleagues, especially during our training period. क्या disclose किया जा सकता है? कितना disclose किया जा सकता है? So to tell or not to tell, if to tell, what to tell, how much to tell? I think that's the question. Can we, Mental Health Act 2017 has right to, there is only right to information, right to be treated privately, right to the, not having their details known publicly. And Mental Health Act very clearly says that you cannot take photograph of a patient while during inpatient or otherwise, and that photograph cannot be made public. And inspectors, in the previous act, there was very clear guideline. Inspectors do not have access to clinical data. They cannot have a clinical record of a patient. Oh, this guy has third-person hallucination. Mr. Hospital Manager, what have you done to this? No, inspectors cannot ask. Inspectors, even Mental Health Act doesn't clearly mention that, but inspectors can ask for the, do you have enough space? Do you have enough recreation facilities? You have bed strength, bed ratio, space ratio, and do you have enough staff? That can be asked. They can visit and ask, oh, are the toilets clean? But they cannot ask about the core clinical content of any individual. That is something which Act is very clear about. But when they go for a tribunal, that's a different thing. If they go for a hearing for discharge or whatever it is, if they go for an appeal, that's a different thing. Then they'll have access to records. When they go for a hearing or an appeal process, that's a different ballgame. Next slide, please. This is one case which I would talk through the entire gamut of psychiatric information, confidentiality, privacy. It's 2015, 13th of July, 2015, Madabushi Sridhar's, he was the information commissioner at the time, Telugu man. And he has done a very beautiful summary of entire thing for the judgment he has given. Mr. Vikar Ahmed, he wrote a letter. He was married, and then his wife had custody of his children. He was earning about 50,000 rupees. And he was asked to give 22,000 towards maintenance of his 3 children who were with his wife at the time, and they were separated. So, ye jo alimony or bharanamu, whatever it's called. And Vikar Ahmed wrote to IBHAS, Institute of Behavioral Health, Agra. He said, I think her name is Zainab or Zaira or something like that. Zainab visited the hospital between periods of 2013, whatever periods it was, 27 to 2013 or something like that. This many number of times. I want to know the records of this patient. I want to have medical records of this patient between this period and this period. And hospital, now it's because it's a publicly funded hospital, they fall under RTI, and there is a responsibility to give certain degree of information. RTI rules are very important in terms of what sort of information a hospital could give and could not give. And the CPIO, the person who is in charge of information, officers in charge officer, or they're called something else, central public information officer. So PIO says, no way. And the first statement he says is, third party, asking for third party information, not entitled to no information given. And this guy appealed now. He says, listen, we can't, I need this information now on the grounds that if my wife is unwell, I need to know because my children are under her care. Now, what did he bring in? So the first information, the principle which was used was the other person, third party or a person who has got no relevance, has no need for clinical data or patient data anytime. So you shall not give information. That was the principle the PIO used. So he appealed saying that his wife has been unwell and he knows that she has attended many a number of times this particular hospital, and they have destroyed all the records. So now give more information. So the appellate authority said, like, what's happening? They asked the hospital. So this hospital said, boss, it's an OP, we give a slip. There is no record of anything. Slip is in possession of the party. The person was called party in this case, patient. So hospital doesn't have a record, no record, we will not give. Now this guy goes further to the commission, information commission, and Madbushi Sridhar very beautifully has done intensive work and evokes all documentation in terms of right from traditional responsibility of a psychiatrist. And then he says a few things, which I read verbatim because it makes it easy. Medical records of a person are generally confidential, considering the Indian Medical Council Professional Conduct Etiquette Regulation 2002, framed under the provision of Indian Medical Act, which in hereinafter called as the regulations, So the medical council regulation says patient's delicacy, secrecy. I think the spelling is wrong in the publication, but they say confidences concerning individuals of domestic life entrusted by patients to a physician and defects in the disposition or character of patients observed during medical attendance should never be revealed unless the revelation is required by the law of the state. Sometimes, however, a physician must determine whether the duty to the society requires him to employ knowledge obtained through confidence as a physician to protect a healthy person against communicable diseases. Because Christian law, leprosy is an issue. If there is leprosy, then marriage becomes null and void according to Christian law. In such instance, physician should act as he would wish another to act towards one of his family in these circumstances. When it's taken into context, I didn't really act in the family like member when the first person came in, the gay person in my clinic. I didn't do that. But I don't feel particularly guilty, but at the same time, I feel wrong. And then there has been another Supreme Court situation wherein he says that Supreme Court says marriage is a union of two souls, bringing in other souls into the world. And that is the nature of the world. Supreme Court specifically mentions that. And there is a need to protect this particular system. I refuse to use the word institution. So in that process, Madabushi Sridhar went on to actually say, is there any information can a public information officer give to this person? And then IBHAS brought out a register which had outpatient consultation visits, 8 visits during the entire period. And the commission very clearly said, this information doesn't have any psychiatric information. It is only information about consultation. How the courts take it in another context, in the marital court, that's none of the thing. But this person is entitled for 2 reasons. One, if the person, the lady Zainab, is unwell, then children are at risk. So to protect the interests of the children, we allow this information to be revealed to this particular party so that the children are protected. So here the clause which has been evoked is safety of the children. So can we get to the next slide, please? Sir, enta time undi, sir? Sir, how much time do you have, sir? Did I overshoot? Okay. All right. Patient's family come to see. I'll just quick run through. Patient is diagnosed with schizophrenia. Patient's family come in and then say, like, am I pelli chestunamandi? We still want to continue to consult you, but we will come with the boy and the boy's family in the future, pretend as if you don't know me, and create a new record. It happens in regular practice. And what do? I mean, it could be a boy or a girl, it could be. And then in this particular context, I said, listen, I cannot really create a new record. I will not lie. One of the biggest thing I tell my colleagues is that if you stick to truth and one truth consistently, I think life is much easier. And when it comes to documentation, make a record and always mention, like, you've seen the person with their spouse, mother, father, whoever comes in, seen Mr. So-and-so with so-and-so, and then don't forget to put the date, time, and the place where you're seeing. If you visit 10 hospitals, and mention that you've seen this particular person in Harsha Hospital, Apollo Hospital, or any other hospital, make it a point, date, time, lagao. This is something, because you never know which document is going to bite you. So you tell something that's going, it might bite you. So we just say, like, give as much information, as relevant information as necessary to take care of the patient. So here I said, actually, no, boss, I can't really create a record. I'll not take care of things. Next slide, please. Quickly, there are a quick slide I wanted to run through for younger colleagues who might be called to court at some point. We all will visit court at some point in our lives. Don't take it for granted. I'm a private practitioner. You'll never be called to court. I work in the hospital, which is protected. You all will be called to court. Somebody will write something about it. This is part of game. Like, if you were to be like, Gullo Pantalaithe court Gulloru. Psychiatrist you will be called to court, and that's enjoy the journey. Don't think because it's adversarial. Gullo Pantulun kuda pilustaru telisu devulu ledu enduku double తీసుకున్నా అని. So like yeah, there was a movie as well. So if you are a psychiatrist and if you are practicing, if you are a psychiatrist having decent enough practice, you will be called to court within 5 years of your practice. That's the nature. And when you go to court, our legal system is adversarial. So people will ask you uncomfortable questions. Legal system is adversarial. They'll make you feel bad. That is the nature of it. It doesn't mean that the advocate doesn't like you or he hates you. That's his job. He wants to make you feel uncomfortable, make you feel this big. That is his job. He's just doing his job. Enjoy it. And there are only two ways of witnesses. You can go fact witness if there's something happened to one of the patients you're treating. If the guy says that you've been negligent or whatever it is, you'll be called in as a fact witness. Or somebody does something and you're an expert, you'll be called in like as an expert witness. If you're going as an expert witness, everybody treats you very well. Yes sir, no sir, and occasionally the opposition might ask you a very awkward question. So how many years of practice do you have, Dr. Praveen? Both Dr. He knows my name, Dr. Praveen. In practice, sir, I've graduated this year. No. In practice, sir, I postgraduate na kirojan. That is not the question. Judge garu ask him to answer how many years of practice he has. So, and by then you're rattled, and then he looks at you and then says like, so this question was asked to me in one of the courts. Sir, and he got this one old book of 1980 written by some Om Prakash, and said, this book says mentally ill people cannot work. Said, sir, these days people with mental illness do work on a regular basis. So what is the percentage of people working? I don't know. Let me go and refer. Judge sir might note this point, sir. These questions, Google also knows answers. This expert doesn't know answers. And this was like, this is true. I'm not joking. So, and then I look at the judge. Judge smiles. Dr. Garu, meer answer cheyani avasaram ledhu. So I tell people like, you look at the judge when they know what is happening. They do understand. And they say like, the judge was very understanding of the thing and the adversarial and aggressive stance. And he told the advocate, manage yourself అని చెప్పినారు. చాలా సీరియస్ గా మీరు మెయింటైన్ చేయండి డీసెన్సీ ఆఫ్ ద కోర్ట్ అని చెప్పి. సో హౌ డు ఐ గో టు ద కోర్ట్? నేను ఎట్లా ఏం బట్టలు వేసుకుని పోవాలా అని మనకి ఇండియాలో చెప్పరు. when I attended my courts for the first time in UK, my boss said, Praveen, get the best of your courts. You should be dressed like you're going for the best of the interview for a consultant post. ఎందుకంటే కోట్ మంచిగా వేసుకోవాలి. And then I said, I got a new tie and tie కట్టుకొని కొత్త టై బ్యూటిఫుల్ టై కట్టుకొని పోయినా. And you said, no, ఇది మరీ కొత్తగా ఉంది అంటే నువ్వు మొదటిసారి కోర్టుకు వస్తున్నట్టు అనిపిస్తుంది, పాత టై కట్టుకో. I'm not joking. This was Simon Dean, my boss. He said like, so court law, you need to present yourself as an expert who knows everything. Courts don't know anything about mental illness. Period. Don't worry. You are the best person to know about mental illness in the whole scenario. And you know most about the patient than anybody else. You think lawyer knows? No, he doesn't know. She doesn't know. So go with all the confidence and go with all your paperwork. Go early, switch off your phone, dress in the finest of the attire, man or woman, whatever way. Not as if you're going for a wedding, but as if you're going for an interview. You should be the best dressed person. And how should I stand? They say 1 shoulder width feet apart. This is something which is really written. So when you stand, if you keep your feet apart, 1 shoulder width, your posture is one of confidence. Don't put your hands in your pockets. Don't take your hand back to the evidence stage. If you're giving evidence, don't take a handbag. If women are going there, don't take. And just take enough papers which are referenced useful. And when you are in the court, your opposition will make you feel uncomfortable. He'll make you wait for hours and hours in a very uncomfortable room. And this is not your stage. Your drama stage is your clinic, your office, wherein you're the boss, you're the king. And this is one place that fellow will make you feel the lowest ever. If you're a professor, like you have 20 people running, medical students, juniors, nurses, everybody's running behind you. And when you go to a court, it's an alien world. The language is very different, the legal language. When you say depression, they don't understand depression. When you say schizophrenia, they don't understand schizophrenia. They understand mental illness according to ACT. Is it curable, not curable? They see things in binary. You say, no, 66% of the people will have good outcome amongst 33%, 15% have poor outcome, 15% have moderate. They really don't want. So this is a binary world of zeros and ones, which is very difficult and which makes you feel uncomfortable because we have the luxury, we have been indulging ourselves in this ambiguous world of uncertainty in psychiatry. Courts don't allow that. So be prepared. Talk to a senior before you go to a court. Talk to a senior. And when it's adversarial, love it. Enjoy it. It's fine. Aur aane do. I think that's the easiest way to go when you're going into court, and everybody will go to court. So next slide, please. Just quickly, we never thought as psychiatrists, marriage would be an important context in psychiatric practice. We have always been taught schizophrenia, depression, bipolar illness as entities in psychiatry. Marriage is a major entity. Marital relationship is a major entity. Marital relationship, everybody who is practicing will encounter within their practice about marriage and the drama associated with marriage and the beauty of the marriage. And let's not, any day when people come in, trivialize the idea of marriage based on the WhatsApp jokes we receive from everyone. And let's not trivialize wives or husbands or marriage itself. And it brings in lots of issues of morality, ethics, and law. I always tell colleagues, like, you need not be good always, you be right always. You need not be, because there is always this assumption that you need to be loyal to the patient. Do the right thing. You don't have to do the good thing. And you don't have an obligation. When you're taking care of a patient, you don't have an obligation to put yourself in the harm's way. You don't have to put in, yourself into a legally vulnerable situation when you are seeing a patient. There is no need for it. Just because the patient has been visiting you for the last 20 years doesn't mean that you create a false record, or doesn't mean that you subvert truth, or doesn't mean that you delete records, doesn't mean that you create edit records from from the past, or because when a document leaves you, a piece of paper, an OP slip which leaves you, assume that 1 million copies of it have been made. If a paper leaves you, 1 million copies are made, don't edit it. Create a new document. If you're editing, say, put a line through saying edited on so-and-so date. If you're correcting a prescription was issued on 24th of February, edited on 28th of February, these changes are made. And especially like, if you give like 4 weeks of lorazepam to a patient, the patient comes and says, lorazepam kaam nahi kar raha, sir. Zolfresh se bahut acha tha, lorazepam kaam nahi kar raha. And they would have actually collected 4 weeks of lorazepam from the shop already. Now, how do you issue Zolfresh? So create a document saying that this prescription was issued on so-and-so date. This is issued in lieu of that prescription. Instead of that prescription. So document it. Edits are to be signed, time dated. That's very important. And don't be heroes in clinical practice. Be a good doctor. Be a great doctor. Be a responsible doctor. But you don't have to love your patient beyond your professional responsibility. You love your profession. That's great. And there is no need to put yourself as a sacrificial goat in the altar of practice of medicine, especially psychiatry. Next slide, please. Thank you very much. You've been a fantastic audience. Thank you. Excuse me.
Thank you, sir, for your presentation. So any questions from the audience?
Thank you, Praveen. In his own inimitable style and very good case examples, actually. From the Supreme Court judgment, it is clear that if there is a harm to the other person, and even in the second case also, the court asked whether there is any harm to the child or whether there is any harm, probably harm to the husband. She is suffering.
Information Commission.
Yeah. So basically, in those situations, probably we can communicate, right? Because they are danger. Otherwise, in the case of HIV, it cannot be corrected, right? So once the person gets HIV, which will be HIV patient, right? But in that young person who is gay, of course, the marriage will be over in months or few months time, whatever. But there is no such harm. So probably we should not tell if somebody is gay. We cannot disclose. That's why I see. But if there is a definite irreversible harm, then we should communicate. Probably we should first inform them that if you don't tell, I am going to tell. Maybe we should do that also.
I see the argument, Keshav, and I don't know if there is a right answer. But the thing is that if somebody has a sexual orientation of a certain nature, if somebody is homosexual in their sexual orientation, would that change? It will not change, obviously. So, and other thing is that it's not an illness like HIV, which has to be communicated. This is not an illness to be, to have for us to protect another individual. It is a choice. It's something which people are. So, is there a responsibility on the clinician's part? I'm in an ambiguous state. I don't know. I don't think there is a responsibility on one day, and the other day I feel, "Arey yaar, wo ladki ki zindagi." But thing is that best part, as you said, like, what happens? Marriage will break down. That's okay.
Yeah, Praveen, it's a nice presentation, and while presenting, you mentioned one very important point, that is seek suggestions from your seniors and teachers. See, whenever we are facing such problem, or we are made to attend any court, it is always better to discuss with your seniors. It is a very important point for juniors. And Dr. Ashok Reddy sir, Raghuram Reddy sir, and Kishan, I used to discuss with them whenever I attend court, because that preparation is very important, as you said. And the second thing is, see, once I attended court in Karimnagar, the issue was the patient is a chronic schizophrenic, and that fellow who married her, he knows very well that she is suffering from schizophrenia, and because she is very rich, and he thought he can have very good life, and marriage has become secondary for his financial problems, and so he got married to her. See, after 6 years, after they blessed with 2 children, now he wanted to go for divorce. And the judge was asking me regarding the diagnosis. She straight away she asked me, what is the diagnosis? Because you have treated her for so many years, she asked me. Is there illness well before the marriage? I told her, see, she is suffering from more than 10 years. She got married 6 years back, and the diagnosis is like schizophrenia. And the boy very well knows that her husband very well knows that she is suffering from schizophrenia, and he met me well before going for marriage, I told her. And see, what is your experience with the case? See, I told her she reached a pre-morbid level. And she asked me, what is pre-morbid level? See, all other skills were very much productive, and as long as she is on the treatment, she never had any breakdown.
I mentioned that, and I told her I have case sheet of the patient. So then she asked me, what is the reason why she's suffering from breakdowns repeatedly after the marriage? I told her, I explained the judge saying that because of the irregularities in the treatment, one. Another thing is pregnancies. Because of pregnancies, she's suffering from breakdowns. See, after all, what is your suggestion, doctor? She asked me. I told her, first ensure that this fellow will look after her properly and they maintain the drug compliance is first thing. Second thing, let him wait for another 1 year and see whether there is any relapse during that period. If she develops any negative symptoms or loses her intellectual abilities or like that, see, then he can decide on his own. But considering the importance of the importance of the marriage, and here there are 2 children. This fellow is making all the nuisance. He's intentionally disturbing her treatment. It seems like that, and you can warn the husband, and you have to take proper. You have to give them proper guidelines to look after the wife with your authorities. So many a times, what happens? We have to use our common sense, and we have to seek suggestions from our seniors, and we have to be very bold enough to be. See, she asked me, what is your experience in your clinical practice? What is the success rate of schizophrenics there? She asked me. See, if it is first episode, I can say proudly, sir, it is 80%. If they are chronic, see, 60% of the times we can maintain their normal life. If they are very chronic and have so many addictions and all the secondary problems, we can't say. It depends on the patient. Right? So it depends particularly for the juniors who are starting their clinics in this scenario, in particular contemporary society. We can be very bold. We can be at last we need to be very scientific. That is what we cannot reveal certain opinions. We cannot come out with our own opinions, or we cannot point out somebody that somebody is at fault. So, thank you.
Thank you, Dr. Sridhar. That's really enlightening. I spoke to Dr. Ashok Reddy many number of times when I was in, before I went to court, many number of times after I came to India, I asked Dr. Ashok Reddy, sir, so, and my seniors have been very kind. They're very accommodative when it comes to these sort of difficult situations. They do understand the travesty of the people who are on the other side, who can be rude and aggressive. They prepare you well. So talk to your seniors. And the other thing, sir, Dr. Sridhar garu cheppinattu, now like 2009, epilepsy is taken off the list as not incapable of marrying. That is out. And now there is enough rulings within the courts that, saying that mental illness in itself doesn't mean that they're not capable of marrying. That clarity has to be there. It is, you need to really demonstrate that their mental illness is not compatible with the healthy married life and inability to procreate and have children. These are 2 conditions which law talks about. So by default, somebody has schizophrenia doesn't mean that it's grounds for divorce, or bipolar is not ground. Bopanna versus another case, which was 2015, very landmark case in bipolar. So it's very clearly said that it's not in itself grounds for divorce.
Good afternoon, sir. Sir, Sir, I have one question, sir. When you presented the clinical scenario, sir, I remembered one of the case. I'm 3rd-year resident, sir, right now in IMH. I remembered a case I saw in 2nd year in one of the night duties. One patient was brought. She was in her bridal gown completely and in Ghagra and all. She was an old case. 1 year back, she had a manic episode. She received treatment. They took it for around 15 days. After that, they did not take the medicines. Now, the family members were saying that since 2 months after her marriage got announced, she was more excited than what generally is expected. And they could not notice that it was an episode. On the day of marriage, like the day she was brought, afternoon 1 o'clock, she got married. And next day morning was the reception. So they brought her in the evening because she was very irritable and she was abusing the in-laws. So they brought her in the evening around 10 o'clock, and then they started asking that, doctor, please stabilize her enough that she can sit in the reception tomorrow. We don't want anything more than that, because if you can give sedative, you can give any injection, but please stabilize her enough that she can sit in the reception tomorrow. And we recommended that she's in a condition where she needs admission, because if we admit her, it will improve better. Then they said that she has already been married. Now if we admit her, her husband will have to come and stay with her, and they don't know about the mental illness. So if we now admit her, they will come to know that the patient is having something like this. So how to handle in such situations, sir? We gave her like valproate, we gave her some medicines for night, but then we told them that the better thing to do is to get her admitted, because it's an active episode and it will be a lot of problem, because we can't do anything that will make her sit in the reception, because we can't guarantee you that that would happen. But they did not stay back. Or so how to take care of such situations, or what to do? Because they come with the expectation that you only fix this problem, like a cycle puncture, like you fix it and let us go.
That's a beautiful scenario. Society has a very beautiful way of dealing with bridal marriage situation. I've encountered similar situations. So this family they brought in, बुजुर्ग लोग they sat together and said, नो लड़की जब ब्राइडल गाउन में रहती है तो जिन्नात असरात पूरे स्पिरिट्स जो है वो पकड़ने की ज्यादा कोशिश करते हैं. जन्नत असरात है, आप दवाई दे दो असरात बोल देंगे. We'll tell people that there is something wrong with this, because she's a beautiful bride, something bad has happened, we'll manage it. So who are we? We manage the situation and let them take a call on what they want to tell. I think you just do your clinician's job for that period. That's what I would do.
Sometimes parents get married, parents marry off their children, knowing fully well they are going to have problem. Probably the main purpose there is to get them married so that the neighbors don't ask the question, when is your girl is going to get married? So once the marriage is over, next whatever will happen, they will take care of it. So we have to bear that in mind. And another word, about the illness, what is the diagnosis? Schizophrenia, bipolar. I always tell them the diagnosis doesn't mean anything. Someone with schizophrenia, he may be sitting in secretariat in the secretary's post, and he may be picking up from the dustbin on the road. So it can be two extremes, that extremes. The diagnosis doesn't tell anything. So understand what is the severity of the illness, prognosis, all those factors. So before telling, I will just tell these two lines that illness means nothing. Psychiatric illnesses, particularly diagnosis. Thank you.
I mean, law clearly says nature and degree. I think we want to take the question. Yeah?
Actually, there have been a lot of questions from the audience. There was an active participation, but like due to some technical reason, we lost most of the questions. But like one question is here from Dr. Jagadish Babu. He's asking, what is the status of premarital counseling in India?
So there are lots of people who practice premarital counseling, and we don't do it as a routine. In my practice, occasionally some couples and families who come in and say like pelli cheskunnaru okkar maatladandi. So not as a formalized practice, no, but certain community work. There are certain Christian faith groups which follow premarital counseling. Catholic Church follows premarital counseling on a regular basis. It is mandated in certain subgroups of Christianity, and conversations are much more open than earlier in terms of bride and groom or potential bride and groom, or alliances, talking to each other, boy and girl talking to each other, and that sometimes they want to go and see some wise person, and you happen to be that wise person. It's not about psychiatric screening interview. I don't think that's what we have done any time. More of the times, like, pilla koncham pelli chesukodaniki anxious undandi. Like, one of my friend's daughter was to get married, and okkar maatladandi, boy ni girl ni pampistam. And then she had apprehensions about, like, somebody touching her at the age of 9. Would she be okay when she gets married? And what do you think of it, man? And I'm fine, uncle, but I just want this to be known to the boy, and I want you to be there when it's told. So this sort of things, but formalized premarital counseling, I think a few people in the north are doing, but not much happening on within the context actually. But that's Dr. Jagdish Babu garu, it's a great business proposition though.
Hello, sir. Just a small question. When we say that mental illness can't be ground for divorce, can it be a protective factor? This was one question asked by the husband of a woman who had mental illness but is denying treatment. And he just wanted to ask from me, can this be a protective thing for me not applying for divorce for her? What can be the answer?
Because I'll use शादी करिए तो सब ठीक हो जाता. There is a concept. Apparently, yes, pitchik mandu pelle. These are phrases which we constantly hear within the community, but we know that marriage is a stabilizing factor, especially for men. People with histories of depression, people with histories of psychosis, but not using the word schizophrenia. Marital relationship, being in a steady, stable relationship has better outcome in terms of mental illness. And I'd say yes, when people bluntly say marriage is a treatment for things, it is actually, it has some grain of truth or elements of positivity in it. So marriage is a healing factor. Marriage brings in affection and companionship and a one-to-one, the legal word they use in certain areas, monopoly on emotional relationship. My wife is mine and my husband is mine. In terms of emotion, sexual monopoly, and also somebody being there for me when I go home, or somebody there for me when there for me in the entire contractual period or relationship period of marriage. So marriage is healing in lots of contexts, but that's not a treatment though.
So I'm Dr. Sindhuri, sir. I'm a assistant professor here at IMH. I have a small doubt, sir. In the second vignette, you presented about the girl with anxiety issues and the gay person. If a hypothetical situation, if we do a complete psychiatric assessment of the girl and there is chance of impulsive traits or something, after marriage, if the news breaks out, she might attempt suicide or something like that. So is there any chance where without revealing the details of the guy, we seek a legal advice before we consider breaching of the confidentiality?
I think it's a messy situation. I would avoid actually. I would steer clear as much as I want, especially as a private practitioner.
Yes.
If they have an issue, they can go to a public sector hospital or a government-funded hospital, public-funded hospital, like government hospital, and they can constitute a panel. Hospital constitutes a panel, and they can decide if that is an issue. Let competent authority of the state. Panel is a competent authority of the state designed for that particular case only. So let it be the case. As a private practitioner, I think I should steer clear, and I have a responsibility of feeding my family.
Okay. Okay. Thank you.
I think we'll close the questions here. If anything else is there, you can talk to Dr. Praveen later on. Thank you.
Thank you, Dr. Praveen Kumar Garu, for the detailed presentation, which started with mythology and concluded with real-life clinical scenarios. Thank you, sir. I request chairpersons, Dr. Ramasubba Reddy Garu and Dr. Chaitanya Deepak Garu, to felicitate our speaker, Dr. Praveen Kumar Garu. Thank you, sir. I request Dr. Ashok Reddy Garu to present the memento to Chairperson, Dr. Ramasubba Reddy Garu. Thank you, sir. I request Dr. Manmohan Raju Garu to present the memento to co-chairperson, Dr. Chaitanya Deepak Garu. Thank you, sir. Thank you, chairpersons, for moderating the session. Now, we are moving on to the third session with the topic, sex and psychotropics. I request Chairperson Dr. B. Rajshekhar Garu to come on to the dais.
Dr. Rajshekhar sir is a professor and deputy superintendent at Institute of Mental Health, Hyderabad. He is an internal expert of multidisciplinary research unit, Usmania Medical College, committee member of medical education and research in Telangana, deputy editor of Indian Journal of Psychiatry, associate editor of Indian Journal of Psychological Medicine, peer reviewer of many national and international journals. His main areas of interest include obsessive compulsive disorder, rating scales and assessment, biopsychosocial concepts. Welcome, sir.
Welcome, sir. I request co-chairperson Dr. Harish Chandra Reddy Garu to come on to the dais.
Dr. Harish Chandra Reddy, sir, current consultant and psychiatrist at Sahara Clinics and visiting consultant at Apollo Hospital, Kondapur.
Welcome, sir. I request our speaker, Dr. Sri Lakshmi Pingali Garu, to come on to the dais. Welcome, ma'am. I request chairpersons to take over the session.
Respected seniors and dear friends, we have a very wonderful speaker, Dr. Sri Lakshmi, and just very like 1 or 2 sentences about today's topic. I think there are 3 S's in psychiatry: sleep, sex, and SLDs. Unfortunately, we are losing them. And I request the young PGs like who are going to be consultants tomorrow to take up these topics as their areas of interest in future. And now I hand over the mic to Dr. Harish.
Good afternoon, everyone. It's an honor to introduce the speaker, Dr. Sri Lakshmi Garu. As we all know, we've just seen her brief bio, and without taking much time, ma'am, please go ahead.
Thank you. Hello. Yeah. So the first speaker said, "Kitne din serotonin ke saath jeena?" Unfortunately, I will plunge you right back into serotonin. So of the 3 sessions, I think mine is the most technically complicated one. But considering that all of us are practitioners and will not have time to look at which receptor this drug is acting on, which how much dosage and all that, so I will want to make it as practical as possible with a little bit of neurobiology thrown in. The first slide, please. Yeah. What happened to? Why are we having only half a slide? Okay, next slide, please. So marriage, as we know, next. Marriage, as we know, is a possibly a legal sanction for the sexual activity and for the purpose of procreation, as defined by Stone as early as 1939. Now, suppose you are the person who is prescribing psychotropics which are going to cause hindrance in the sexual process. What are we as psychiatrists supposed to do? Are we going to change the medication, risk a relapse of the disorder? Are we going to continue with the medication and risk the marriage? So there's a tightrope walk for all of us psychiatrists when we're dealing with sexual disorders, especially in the context of between the illness and the side effects, of which I believe sexual disorders are a very neglected topic. The next slide, please. The psychotropics I'm going to cover, there are many, but what I'm going to cover basically are the antidepressants, antipsychotics, benzodiazepines, and the mood stabilizers, because they are usually often used and due to the paucity of time as well. Next slide, please. So we have so many questions coming up to us, especially when they're just about to get married. For instance, a patient of mine who's on 3 different serotonergic drugs for his severe OCD, his parents come and say, can we get him married? So when you take a sexual history, he's having so many sexual dysfunctions, and he's not ready for marriage. But marriage, madam, card to chap gaye hai, the marriage is in 3 days time. So these are the kind of situations we often come across in clinical practice. Then what are we supposed to do? Are we going to stop the medication? Are we going to continue with the medication? What is it that we are going to do? So can my child marry while in this medication? Will they be able to perform sexually? Will this affect the ability to have children? Will it affect their pregnancy? So many questions and so few definite answers. Next slide, please. Sexual dysfunction, therefore, is defined as any dysfunction in the 3 basic phases of the sexual cycle, whether it be desire, arousal, and the orgasmic phase. Next slide, please. Next. One of the most distressing sexual dysfunctions, unfortunately, are one of the most distressing the side effects which they have. They contribute to a very poor quality of life. They also lead to non-compliance or dropout of treatment. The problem with us is many of us do not ask about sexual dysfunction. Studies have shown that when you don't ask, spontaneous reporting is only 10 to 20% of sexual dysfunction, that doctor, I'm having such and such a problem. But when you actually do ask, or at least assess properly clinically, even with the basic history taking, the amount of reporting actually increases right up to 70%. So imagine the number of patients who have slipped through the cracks, who have not told us that they are not able to perform, and therefore they have stopped medication. More so, I think with a lot of problem with female psychiatrists as well, where the males do not generally open up unless we specifically ask them and tell them that we're actually comfortable discussing this with you. There are patients who have come up to me and said, "Mujhe nahi pata, doctor sahab, whether I should tell you all this, but I'm having sexual dysfunction." Who else will you tell but your treating doctor, right? So it was a responsibility of the psychiatrist to tell them that you could also have these issues, and if you're having them, please feel free to report and we will work around them or solve them. Next, please. So as we all know, just to recollect, I'm going to tell you a few brief things. We know that I've divided it. Basically, I'm not looking into resolution phase and all that. I'm basically dividing sexual dysfunctions as dysfunctions of desire, dysfunctions of arousal, and dysfunctions of orgasm. Next one, please. Just to take you briefly into the neuroanatomy, you know that sex is in the brain, in the mind. So unless you are actually willing to perform, your body will not cooperate. But is it only one single part of the brain that is acting in your for the sex? It is not. There are a lot of factors. One is a cognitive appraisal of the situation, cognitively with your brain that you think. Then usually it is the inferior parts of the brain that are involved, that is the orbitofrontal and the inferotemporoparietal. Then the emotional part of the brain also needs to get involved for the sexual act. This is mostly the components of the limbic system, that is the amygdala and the insula. Then there has to be goal-directed behaviors. Okay, I'm aroused, I have an object, and now I have to perform. This is done by the striatum, the cingulate cortex, and the substantia nigra. In order to perform, your body has to react to it. This will again is being taken care basically by the hypothalamus. All together will lead to sexual activity. Why am I emphasizing on this? There can be dysfunctions, or your drugs could affect any part of this in order to cause a dysfunction. Next, please. Just a rule of thumb, so that you understand what you're seeing when you're seeing a patient is high serotonin, sexual dysfunction. Low dopamine, sexual dysfunction. Low norepinephrine, sexual dysfunction. High serotonin means naturally your dopamine and norepinephrine are getting reduced. This is not for the students. This is for practitioners like us who are having difficulty remembering all the neurotransmitters and all. So we grossly remember serotonin बढ़ गया, sexual dysfunction बढ़ गया. Serotonin बढ़ गया, dopamine, norepinephrine will come down, which again will lead to sexual dysfunction. Dopamine is a part of the reward system. So desire, D for D, desire is for dopamine. Norepinephrine is a sympathetic system. It is responsible for arousal. Just remember this much when you are using a patient, when you're using a drug, this will be enough to determine which part of sexual dysfunction you will be coming out with and what will happen and what are the antidotes. Acetylcholine helps in erection, anticholinergics will reduce. So please remember it this way. Next one, please. How frequent are they? This is general public, not having mental illness, not having any kind of treatment.
If you see any sexual disorder, 1/3 of the world's population, of male population, is anyway suffering from one kind of sexual disorder or the other. Erectile dysfunction increases to half the population when you look at males between the ages of 50 to 70. Premature ejaculation is also very common, affecting 20 to 30% across the globe in all age groups. In untreated depression, sexual dysfunction, both genders, it is about 50%. And worsening or emergence of a sexual dysfunction in females up to 65% and up to 57% in males. When you start treating them, sexual dysfunctions may re-emerge or emerge for the first time. Next slide, please. Therefore, till now we've understood that sexuality is a bio-psycho-social phenomena, which means your biology, that is the brain and the neurotransmitters that I've told you about, the psychology, your current emotional state, and the surroundings, your partner, the situation in which you are in, all this will make a difference in your sexual life. So before you blame the psychotropic, it's a knee-jerk reaction for us to, when people say that, is this, sexual dysfunction because of your medication? Immediate knee-jerk reaction for us is to remove the drug. So please consider that sexuality is a very complicated issue. It is guided by many factors, and therefore your drug could or could not be contributing. Make sure you're taking the right decision. Next slide, please. So before blaming the psychotropic, look for physical health of the patient. Many comorbidities like diabetes, hypertension, hypercholesterolemia, all affect sexuality or the sexual performance. Mental health, basic depression, anxiety can also affect. The psychological attitudes, relationship with sexual partners. Many of them come and say we cannot perform. And when you look at their marital issues, they're fighting with each other every day. How can there be a physical relationship when there is a basic affection or even an understanding missing between the partners? So this is where you need to address before you go to your drug and say, Acha, my drug is responsible for this. Sexual, therefore, just a point to ponder or to highlight on, sexual dysfunction is common in the general population. And when you're looking at our drugs causing sexual dysfunction, desire and orgasm are most commonly affected in men, whereas arousal is more commonly affected in women. Next, please. What are the consequences then? There are many consequences, right? It affects the relationship, it affects the quality of life. And for us, leads to treatment, dropout, and worsening of the mental health state. Next, please. So assessment. Now, when we're talking of, in my presentation, what I want to cover is only the sexuality or the sex with a psychotropic. I have a reason for that. When I was given this topic, I was told that you should talk right from sex to the pregnancy and lactation. Now, my belief is that, and especially after reviewing all this afresh, what I realized is there is a huge component called female sexuality. And in the process of always looking at it from the point of pregnancy and lactation, we have somehow diminished the woman as a sexual being, having natural desires. So my focus of presentation would be only on sexuality, including and especially focusing on female sexuality, which I believe none of us ask. I think when I asked myself this question is, why don't I ask? I think somewhere in the back of my mind, I also realized that symptoms తగ్గిపోయి కదా, the patient is no longer suicidal, patient is no longer having delusions, hallucinations, sexuality tarvata చూసుకుందాం. I think that is a common thing that we all have. But when people were asked, how distressed are you because of your sexual dysfunction, they have rated it on par with their positive symptoms. So if I'm having hallucinations and I'm also having difficulty with orgasm, for me both of them are equally important, and who but the treating psychiatrist to deal with it. Next, please. No, wait with this, please. How do we then assess? One is direct history taking, which we often miss. So what was your fantasy life? When my PGs ask from the proforma, tell me about your fantasy life. When did you first learn about sex? What are your masturbatory practices? Somehow, when it comes to interpersonal relationships, we do not ask much about how is your sexual life now. So this is something that we should focus on. Like I've already pointed out to you earlier, when people are not asked spontaneously, only about 10% come up. When they're asked specifically, this increases to 70%. These are the various sexual rating scales. As you know, sexual experience rating scale is the most commonly used 36-item scale. Changes in sexual functioning scale is a self-rating scale, sex effect scale, psychotropic associated sexual dysfunction questionnaire. This is especially for the PGs if you really want to work on how psychotropics are affecting. This is one questionnaire that you could use. Next, please. What is the incidence? So let's just now, I'll focus on, like I said, 4 categories of drugs, of which first is the antidepressants. I promise to leave you in time for lunch. So I run through my slides, so therefore I'm the best speaker pre-lunch session. I will not keep you for too long. Okay. Incidence is about 50 to 75%. So, like I told you, jahan serotonin hai, wahan sexual dysfunction hai, S for S. So, any drug which has a strong serotonergic action will have sexual dysfunction. So, SSRIs are blamed, or blame is the wrong word. SSRIs is the culprits, of which paroxetine is paroxetine, sertraline stand high in that list. In addition, clomipramine from the TCS, is also strongly serotonergic because we use it in OCD. That also causes it. SNRIs, venlafaxine itself will cause. So now, suppose you take a drug which has mixed group of action, like say, which has only an effect on norepinephrine, or which has a serotonin antagonistic effect, like mirtazapine, like duloxetine, like milnacipran, you will find that their sexual dysfunction starts reducing. Jahan pe serotonin come and norepinephrine and dopamine badha, there the sexual dysfunction condition is less. So drugs which have multimodal action, like vortioxetine, I hope I pronounced it right. So this is the one which will have the least sexual dysfunction. What are the kind of sexual dysfunctions you'll have? They will affect all the three phases: desire, orgasm, arousal, and anorgasmia is the least tolerated. I'm not able to have an orgasm, or I'm having dry orgasms, or I'm having very delayed orgasms. These are usual complaints which will come up when you give a SSRI. Next one, please. However, not everybody develops. If you want to go a little genetically, you will find that there are people who are slow metabolizers. So paroxetine, if it is metabolized even slower than normal, naturally this person will have more sexual dysfunction. There are genetic alterations in the serotonin transporter. So the more serotonin in the cleft, it lasts longer, the greater will be the sexual dysfunction. However, it is, as practitioners, we are not much bothered because we cannot detect it. But the factors that we can be aware of is old age, male gender, low education, unemployment. These are observational studies that have been done. Other physical illnesses and multiple drugs which may be contributing to the condition. Next one, please. How do you manage such a case then? First of all, the best is to prevent it. Second is to wait for the symptoms to subside. Apne aap chala jayega. Let's sit and wait. I've done this with many of my patients. Switch the drug, or you add on according to the dysfunction. We'll go into each one. Next one, please. Prevent. Now, supposing you have this young man who's come to you with depression, and he wants to get married in the near future. Now, knowing that your SSRI can cause 50 to 75% of sexual dysfunction and may cause problems in his marriage, your choice will naturally then go on to something like bupropion or mirtazapine. How, of course, you have to look at other side effects like weight gain and sedation with mirtazapine. But if you want, since this is your priority now, that he's going to get married in the next few months, then this is a better drug of choice for you. And studies have shown that fluoxamine less than 100 mg is not so strongly serotonergic, or partially serotonergic drugs like desvenlafaxine below 100. Now, especially because suppose you have a patient who has OCD and you need some amount of serotonergic action, you cannot give escitalopram, you cannot give sertraline, you cannot give paroxetine. Could you try with fluoxamine less than 100? Next, please. Wait for spontaneous remission. Does it work? We'll say, acha, it sometimes starts in the beginning. It will be usually when sexual dysfunction starts, it usually starts within the first 1 to 3 weeks of starting your medication. So shall we wait for it to come down and see whether your body is adjusting or not? What do studies show? It is seen that 80% do not improve even after 6 months of waiting. So waiting is certainly not an option unless that is the only drug that has affected your patient and he or she is willing to wait. Lowering the dose, it is seen that in some studies have shown that if you lower the dose by half, your improvement by 75% takes place. But you're again taking a risk for relapse. Please keep that in mind. Then is the add-on treatment. Add-on treatment depends on what you're dealing with. Next, please. So if for erectile dysfunction, what are you going to do? Phosphodiesterase 5 inhibitors are there. Sildenafil is there. Tadalafil is there, which are usually available in the market. Sildenafil problem is you need planning of the sexual activity. You have to take it about half an hour to 1 hour before the sexual act with all its side effects of headache, flushing, and so on and so forth. Tadalafil sort of helps in this because it has a long half-life and therefore can also be given as a once daily dosing. Studies have shown, which this I've discovered for the first time, that tramadol given 50 mg 2 hours before sexual activity also helps. But are we willing to take a risk with tramadol given its addiction potential? Is something we have to ask ourselves as practitioners. Next one, please. For anorgasmia, I just told you, raise the serotonin, worsen the orgasm. Lower the serotonin or increase the dopamine or norepinephrine, it will help. Read the slide on based on that. 5-HT antagonism by 5-cyproheptadine, buspirone 5-HT1A partial agonism, yohimbine alpha-2 adrenergic agonism, amantadine dopaminergic agonist, and so on and so forth. These are the drugs which can be used in your daily practice, of which commonly used, what we use is possibly bupropion and mirtazapine or buspirone can be used. Next one, low desire. Very difficult to treat this. Adding aripiprazole as a due to partial dopamine agonist can help in women specifically. In men, it is a little difficult. Bupropion could be one option when you switch completely for desire. So it's easier to treat the arousal. It is easier to treat the orgasm. A tad difficult to treat the desire. Next one, please. Other option is to give weekend holidays. Can I stop the drug for 24 to 48 hours before planned sexual activity, especially for people who are planning for children and they want to plan their sexual activity? Could this be a good method to do? Again, the risk of relapse is there. The other option is to reduce the drug by half during this period and then continue, but not proven to be as effective as either adding on or switching the drug. Next one, please. Switch the drug, like I've already told you. You need the serotonic action. You can do with a lower dose. Go with fluoxamine below 100 or desvenlafaxine below 100. Bupropion improves all parameters, including desire, as does agomelatine. Now, there's few papers that I've reviewed from 20, 21, and 19 have batted very strongly for agomelatine, though we not using it much. I wonder why. Mirtazapine also has shown improvement in 70 to 90% of patients. However, the side effects are sometimes detrimental, especially if a young lady just married. Difficult to give mirtazapine considering she can put on lots of weight. Next one, please. So this is in summary of what I've told you. The slide, I'm not too sure whether you are, I will read it out to you. So the desire is low, switching to bupropion or mirtazapine is a better option to take. If you have an orgasmic, everywhere switching is given as the first line of treatment. You're not able to deal with the drug, sexual dysfunction is very high, switching the drug is a better option. Next one, please. Next. Non-pharmacological methods, physical activity, lifestyle changes, acupuncture. I don't know if I put a query, but the papers are saying acupuncture. Psychoeducate, and especially if the depression is chronic, very severe, interfering in the sexual life, married, family complete, you teach the partners for non-sexual physical pleasures from each other or a better emotional connect with each other rather than the sexual. So sometimes when we have no other options left with us, this is one option that we could use. Next, please. So in women, why have I said I will want to specify a little more? Antidepressants reduce desire by 72%, arousal in 83%, orgasm in 42%. Sexual dysfunction starts within 1 to 3 weeks. That means desire reduces before the antidepressant effect starts. 15% of women stop medication due to this. Most of them do not tell that they have stopped because of this reason. However, there's a caveat when it comes to women. Most women complain of sexual dysfunction without expressing too much distress about it. Like they will tell you that I am having difficulty arousal. My husband wants me to participate. I'm not able to do so, but I am not very bothered about it. When your patient is not bothered, you refrain from interfering, especially if the depression is more severe. Next one, please. This is a study done on Indian women on using psychotropics across all psychotropics. And it was seen that 2/3 reported decreased libido, half of them decreased frequency of intercourse, and 1/3 reported reduced sexual responsiveness, decreased lubrication, and decreased sexual satisfaction. Next one. Again, the same policy applies, wait, switch, or add, right? Change to non-hormonal contraceptives. Sometimes the hormonal contraceptives themselves might be interfering, and therefore that's the first practical thing that you could do. Emphasize on, like I've already told you, emotional versus the physical relationship. Next one, please. Management. In arousal, difficulty, the woman is having arousal difficulty, this is something practical you can apply. Sildenafil is not found to be very effective in women. However, if this woman exercises, say a cardio or a weight training exercise, strengthening exercise for half an hour to 1 hour before the sexual activity, it is found that the sympathetic system is activated. Therefore, her arousal will also increase. Simple practical tip that you could tell your the patients. In orgasm, it is because they have a SSRIs or SNRIs have an anesthetic effect. It increased serotonin has an anesthetic effect on the stimulation. So intense stimulation of the vibrator to counter the reduced stimulation because of the drug. Desire, again, like I told you, bupropion 150 mg acts good. Even aripiprazole add-on acts good. 300 mcg of testosterone transdermal patch, but it is not FDA approved and I have never tried it, so I cannot recommend that. Next one, please. Does the sexual dysfunction persist? Okay, ab to ho gaya, I have given you medicines. Now I have stopped the medicine. Will this sexual dysfunction, will it get over, doctor? Most of us say, yes, it will. By the time we stop the medicine, it will get over and you will come back to your normal self. It is not true. It is not true. What happens is some people, 50% of them, even 6 months after stopping, will continue to have something called penile anesthesia and therefore lack of arousal, or they'll also have pleasureless orgasms and therefore complete lack of desire in having the sexual act. In women, there is reduced arousal. So sexual dysfunction can persist. Okay. So if a patient is coming to you and saying that I stopped the SSRI 3 months ago, but I'm still not adequately aroused, please consider the previous SSRI may have caused it. Okay. Next one, please. Sexual dysfunction. Okay. So that is about women. In specific, like I told you, I wanted to specify that women also suffer from dysfunction, sexual dysfunction, quite a lot of them. So when you looked at the numbers, it is 2/3 of women are actually having this with SSRIs. Now let's look at mood stabilizers. Mood stabilizers, standalone mood stabilizers like valproate and carbamazepine, compared to them, lithium has the worst overall sexual dysfunction. And this worsens considerably when you add benzodiazepines to it. So it reduces sexual thoughts, desires, and satisfaction, worsens erectile function, reduces testosterone levels, and also reduces the nitric oxide mediated relaxation. Does it mean that I will stop lithium? No. What you will remember is that this is a one possible side effect with lithium. Lithium has tremendous advantages to be used. So this should not deter you from using it, but should be at the back of your mind that if a patient is complaining about it, it could be because he's having depression per se, which has caused it, or the drug you're using also may have caused it. Next one, please. Valproate and carbamazepine reduce desire and orgasm in women and erectile dysfunction in males. And what do? Either you switch the drug or you reduce the dose. Which are the drugs that you could use? Lamotrigine, oxcarbazepine are supposed to be very minimal effect on sexual dysfunction. So that could be your options. A trial of, one study showed a trial of 50 patients reported improvement in sexual dysfunction and adding 240 mg of aspirin. I'm not too sure whether I can add so much. Next one, please. Sexual dysfunction with benzodiazepines, alprazolam, clonazepam seem to be the major culprits. They act through the GABA receptors, which will reduce desire, arousal, and orgasm. But the good news is they do it only at a higher dose. Like when you're going up to 3 mg, 4 mg, it is the time, but they do it. Usually at low doses, they do not. Next one, please. Most importantly, there's this patient of mine who called up and said, I am planning for pregnancy. When they did my sperm test, and he's on paroxetine for many years from me only because he suffers from very severe panic attacks. And my sperm count shows all spermatozoas abnormal. Do you think paroxetine is causing it? Off the cuff, I told him, no, my drug does not cause any such thing. And I regret saying that because now that I'm doing the review, I realize that yes, they do cause. The bad part is it causes, the good part is it is reversible. So both of this you should remember. I'm sorry. Anti-epileptic drugs like lamotrigine or oxcarbazepine do not affect sexual dysfunction, do not affect the spermatozoa also. However, SSRIs can reduce the sperm count, they can reduce the sperm motility, they can cause higher number of abnormal spermatozoa and increased sperm DNA fragmentation. It improves on stopping after 1 to 2 months. Because the spermatogenesis takes place about 72 days, once in 72 days. This means it's a post-testicular process. There's no data on SNRIs and NDRIs. TCA sexual dysfunction is much lower than SSRIs. And selegiline seems to increase the sperm count. By the end of my presentation, you will be convinced that bupropion people have sent me to promote their drug. Next, please. Sexual, so we'll come to, this is the last part of my presentation, sexual dysfunction due to antipsychotics. So what are the causes which cause we all know, we have been reading, and we are more accepting of the fact that antipsychotic can cause sexual dysfunction much more than the fact that an antidepressant can cause, because we read about the prolactin and how it causes and all that. So the severity of psychosis per se can affect the sexual functioning. Severity of psychosis can prevent expression of sexuality. The depressive symptoms that are comorbid in a psychotic process can reduce the sexuality. The negative symptoms can do that. The comorbid addictions can do that. The comorbid illnesses to which our patients of schizophrenia are prone to, like diabetes, hypertension, so on and so forth, are also susceptible. So, and like I've already mentioned to you, when patients are asked to rate the distress due to sexual dysfunction, they rated it on par with their positive symptoms. So let us not take their sexual dysfunction lightly. Next one, please. Mechanism of action is multifactorial. D2 blockade. Again, same thing I'll repeat. Dopamine, norepinephrine, come ho gaya, sexual dysfunction, serotonin बढ़ गया. Remember that for always. D2 block can increase prolactin, which again reduces desire. D2 block is blocked in the reward pathway, reduces desire, and so on and so forth. Okay, next one. Prevalence with antipsychotics, women 30 to 80%, men 45 to 80%. So the upper limit is 80%. That means most of our patients, of which thiridazone up to is the maximum. Clozapine itself, but remember clozapine can cause hypersexuality as well. Qutipine, aripiprazole, ziprasidone are all drugs which cause very less of these sexual dysfunctions as compared to risperidone and haloperidol. Olanzapine below 15 and 20 is almost like Qutipine. Qutipine below 500 again is like aripiprazole. The more higher you get, like olanzapine, you go beyond 15 to 20, or Qutipine, you go beyond 500, the sexual dysfunction increases significantly. Next one, please. So again, management will be the same as antidepressants except for a few modifications. Always before blaming your psychotropic, look for other causes, including partner relationships. Exclude comorbidities, ask for other drugs of abuse, assess the serum prolactin, and treat the comorbidities. Same procedure, wait, reduce, switch, add. Next one, please. Wait for spontaneous remission. In this also, only 5 to 10% remit in 6 months. So not a very good idea to wait unless you have no other options. Dose reduction, 73% of patients on risperidone, it has been found improve when dose was halved. What can you switch to? You can switch to prolactin sparing drugs like aripiprazole, olanzapine, Qutipine, lurasidone, and ziprasidone. Next one, please. You can add, depending upon the condition, for low desire, you add aripiprazole, you can add sildenafil in men for erectile dysfunction, tadalafil and others. And you can also augment your antipsychotics with mirtazapine, pramipexole, and even imipramine. Please keep note of the addictive side effects many of these drugs may have. Next one, please. So these is basically to, here also they say switching is a first alternative, switch to aripiprazole in almost all, whether it be desire, orgasm, erectile dysfunction, vaginal lubrication, switching to aripiprazole seems to be the best mode of treatment. Next one, please. So the take home messages are, sexual dysfunctions are very common with psychotropic drugs. Ask, I repeat, ask, because when you don't ask, it's 5 to 10%. When you ask, it reaches as much as 70%. This is one of the major reasons for non-compliance, impaired interpersonal relationships, and poor quality of life. It is as distressing as the illness is. Most are reversible, but some tend to persist. And for a psychiatrist, it is a tightrope walk between the symptoms and the side effects. Thank you.
Thank you, Sri Lakshmi, for the good presentation. Before opening it up for discussion, like one thing, like what you have really, you brought out in your presentation, as psychiatrists, we feel very uncomfortable taking sexual history. I think that is very important. That's the take home message. In my practice, I always ask female patients for their LMP. Indirectly, something indicative of sexual history, but being a male, it's little difficult for me unless a little patient actually is complaining. For all the males, I definitely ask about sexual functioning at baseline as well as follow-up. I remember one patient with paranoid schizophrenia. He did not tell me, but then he used to ask his father why this doctor always asks about my sexual functioning. So that has actually, it had reached a delusional level. Like he was very much concerned, and it became a very paranoid aspect of his thing. Like how come, why doctor is always asking about my sexual functioning? So that's the thing. And now I hand over the mic to Dr. Harish.
Thanks, ma'am. It was pretty quick and very informative indeed. Should I take some questions? Dr. Indumati has a question about what about bupropion-induced seizures? I had it in a patient, and since then she's apprehensive to start with bupropion. That's her concern with bupropion.
Yeah, I think for any drug to use, you have to first understand the side effect profile of the drug, right? Just because you want to treat the sexual dysfunction does not mean that you will, induce another problem. So if bupropion is not being an option, mirtazapine is always an option, or agomelatine is an option. So even when you switch, the side effect profile should be kept in mind. For example, since we're on the topic of bupropion, we know that it causes an initial enhancement of anxiety and patient gets restless, nauseous. All these things should be kept in mind, especially if you're switching to an already anxious patient. So are you treating the sexual dysfunction and worsening the anxiety? Are you treating sexual dysfunction and worsening or inducing a seizure if the person has a low threshold? So these, even while switching, side effect profile should be kept in mind. No experience. Although it is recommended, I have no personal experience. Maybe seniors could tell us.
Switch comes before
Yeah. So if your question, for the sake of the online audience, whether you can switch or add on, which comes first, it entirely depends upon your patient profile. Now, if a patient has responded admirably to our antidepressant and has very severe depression, and you want to address the sexual side effects, I think an add-on is a better option. If a patient already is not doing so great, and the sexual dysfunction is very bad, and is sleepless, can put on a little weight, and you find that mirtazapine is a better option here, then definitely switching is an option. But a word of caution is, when you switch, you don't do it abruptly. You taper one whereas you start the other, and the patient has to be cautioned that when there is a transition between one drug to another, that one blood level falls and other increases, possibility of breakthrough symptoms will be there, and they have to be psychoeducated about that.
Doctor asks, ladies having amenorrhea for 1.5 to 2 years on risperidone, which is the best drug to switch to?
From what we have reviewed, aripiprazole seems to be the best drug to switch. But rather than direct switching, what I would do is add a low dose of aripiprazole, and to see whether usually the cycle starts to restart by when you're reaching up to 5 to 10 mg. Also, the cycles restart. And if you're finding that the patient is actually doing well, you may also consider cross tapering risperidone with aripiprazole and not expose the patient to 2 different antipsychotics.
Thank you. Anybody on the floor?
Nice presentation, madam. And I have few observations from my practice to add on, and for your opinion. First thing is adding antioxidants to our prescription, like omega-3 fatty acids or E vitamin, D3. All those things can enhance the performance of the person. And second thing is using the low dose of SSRIs. For example, if we are using fluoxamine for OCD patient, it is 50 mg plus some add-on with clomipramine or other TCS. That can save that can help the patient in coping up his problems and side effects. Thank you.
Yes, sir, I agree with this.
Good afternoon, ma'am. I'm Aditya from IMH, final year PG. Ma'am, I've observed that few of the closed ward patients, they do complain of not having erections, and they complain about their sexual desires. I mean, though they're in closed wards, which means obvious no sexual intercourse activity, but they complain, they request for stopping the drugs which cause dysfunction. Like, how do we approach such scenarios?
You're talking of partnered sexual activity. Not all sexual activity need to be partnered sexual activity, isn't it?
Yeah.
So if the patient is showing distress just because in his closed ward, it does not automatically negate his rights to have sexual desires or erection, right? So if therefore you need to address this problem. So in any one of the methods, it comes under his basic human rights that he wants to feel certain emotions which he's not able to feel because of the drug that you started. So in my opinion, it is his basic right to need that. So you can add or you can switch or you can, reduce whichever your patient permits. I think it should be done.
I have two questions, madam. I'm Dr. Syed Nasaruddin from IMH second year PG, madam. Two case scenarios, one adding to what Dr. Aditya sir has asked. There's a schizophrenic patient. He's also not currently sexually active. He's separated from his wife. So he also complains of sexual problems. So how do we know that it's not due to the illness itself? And he attributes this illness to the medication. And he is remitted from the illness because of the medication. Like after a trial of few medication, and then we had come to olanzapine, and then he's telling that he was feeling he started having this issue after starting olanzapine. So how do we know that the problem is not due to the illness itself? It could be a negative symptom of schizophrenia, and or if it's due to the drug itself. And another question, another case scenario is of an OCD patient. We know that they are usually on high doses of SSRI. So after that, once they have got treated with their obsessive compulsion, then they come up with this problem of sexual dysfunction. So how do you manage or go about these two cases?
Okay, for your first case, I think again the answer remains the same, is that you need to rule out all comorbidities or all conditions which are affecting your sexual dysfunction, whether it be negative symptoms of schizophrenia, whether it be, but if your patient is so articulate enough to come and tell you that I am separated from my wife, but I am still having reduced sexual desire or arousal, definitely you can rule out negative symptoms by that only, I think, right? So detailed history is what will help you here, but I want to reiterate that it is his choice. It is his choice to want to have sexual feelings. Okay, even if the circumstances may not permit partnered sexual activity, it is his right to want to have sexual feelings, and we should do something about it. As for the SSRIs, it is a very tricky situation for all of us. If you touch the SSRI, the OCD worsens. If you don't touch the SSRI, the sexual dysfunction is there. So in this case, what we need to do is to augment with something which will help to reduce. Mirtazapine is one option, okay, where you can use bupropion as one option, or specific to that, suppose desire aripiprazole, or whether you add sildenafil as in when tadalafil daily, this kind of additions depending on the exact phase of the sexual cycle that it is addressed. But please do address it. That is what I'm trying to say, is that you have exactly reflected how I started my presentation with. Just because the symptoms are there of a psychiatric patient does not negate his right to have sexual feelings. So you have to address it.
Ma'am, I have a question, ma'am. Some of the patients, they have a doubt that they have a habit of masturbation since so many years, and they are asking that now we want to stop. So what we can do?
Why do they need to stop?
Because they feel that, okay, whatever I am doing, I feel this is something wrong.
So you need to correct the cognitions, not the process, right? So as long as a person is, though it's a little out of purview of this, I think, but as long as a person is not neglecting alternate activities and indulging only in masturbation, it's a healthy practice and a healthy outlet. So you need to correct the cognition rather than the masturbation.
Okay, thank you. Thank you, Dr. Sri Lakshmi Garu, for your clinical pearls of wisdom. I request chairpersons Dr. Rajshekhar Garu and Dr. Harish Chandra Garu to felicitate our speaker, Dr. Sri Lakshmi Garu. Thank you, sir. I request Dr. Nivedita Garu to present the memento to co-chairperson Dr. Harish Chandra Reddy Garu. Thank you, ma'am. Thank you, chairpersons, for moderating the session. Thank you, speaker. I request all the delegates to please join us for lunch. We will resume our session by 2:30 p.m. Thank you. Before only, ma'am.
Details better.